Bismillahirrahmanirrahim. Assalamu alaikum. Good morning, good afternoon, good evening, and welcome all of you, uh, all the speakers, panel, expert panelists, the participants, and welcome to the day 4, which is the last day of the Khan University Hospital Annual Cardiovascular Conference Pulse 2021. We are going to start the session on adult congenital heart disease and pulmonary hypertension. This year, as we all know, the theme for the conference is gender matters. And we have an esteemed group of expert panelists and the speakers. Without taking more time, I would like to briefly introduce the panelists, and that will be followed by the speaker's talk. Each speaker talk will last for 15 minutes, followed by a 5 minutes Q&A session. For all of you, please, and especially for the participants and the listeners, please send your questions to the AKU host in the chat box. And that will be directed to me, and then we can discuss it during the Q&A session and the panel discussion in the end. So let's start with a brief introduction of all the panelists, and then we will start with our talks. We have a very nice group of panelists today. I'm so honored to have all of them with me. My first panelist is Dr. Babar Hassan. Dr. Hassan is an associate professor, Department of Pediatric and Child Health, Afghan University, Karachi. Dr. Babar completed his medical degree from the Afghan University in 1999. He's an American board certified pediatric and pediatric cardiologist. Dr. Hassan is currently working as an associate professor in Department of Pediatrics and Child Health. He has more than 12 years of experience in clinical services, education, and research. His research area of interest are developing the quality metrics, value-based healthcare, and the use of artificial intelligence with the purpose of task sharing and intelligence augmentation, especially in the lower middle income countries. Thank you, Dr. Babar, for honoring us today and joining us in this session. Our next panelist is Dr. Amy Verstappen. Thank you so much, and she is an associate professor in the medicine and pediatrics at the Harvard Medical School. She completed residency in medicine and pediatric cardiology and adult cardiovascular disease at Duke University. She is a section chief of the Boston Adult Cardiac Diseases and Pulmonary Hypertension Program and a fellowship director of the Adult Congenital Heart Disease Program at the Harvard Medical School. Dr. Valent's research interest includes strategies to improve the outcomes of women with the heart diseases during pregnancy. Her other research interests focus on the use of imaging to determine mechanisms that contribute to the ventricular dysfunctions in adults with congenital heart diseases. Thank you so much, Dr. Mary, for joining us and honoring us. I hope that we will definitely learn something very new and very interesting from you, from the discussion. That will be a productive discussion. We have our next very esteemed panelist, Dr. Ali Zaidi. Dr. Zaidi is an adult congenital heart disease specialist. He received his medical degree from the Afghan University and Hospital, Afghan University, Karachi, Pakistan, and completed his combined internship and residency in internal medicine and pediatrics at the Penn State University Hershey Medical Center. Dr. Zaidi completed his combined fellowship in both pediatric cardiology and adult cardiovascular diseases at the Nationwide Children's Hospital and the Ohio State University Medical Center. Dr. Zaidi is one of the few selected cardiologists in the US who are board certified in pediatrics, internal medicine, pediatric cardiology, adult cardiovascular disease, adult echocardiography, and adult congenital heart diseases. He has served as a director of research at the Columbus, Ohio Adult Congenital Heart Disease Program and was part of the several national multi-center trials. Dr. Zaidi is the current president of the Alliance for Adult Research in Congenital Cardiology. And he is, I can say, pioneer in ACGME approved ACHD fellowship training program building, especially in the New York. He is currently serving as a director at Mount Sinai Adult Congenital Heart Disease Center. Thank you, Dr. Zaidi, for joining us. Our next panelist is Dr. Shazia Mohsin. Dr. Shazia is an assistant professor and pediatric cardiologist at Afghan University, and special interest is non-invasive imaging, including fetal echocardiogram. She's the first international member of the American College of Cardiology's Adult Congenital in Pediatric Cardiology Quality Matrices related to non-invasive laboratory. Thank you, Dr. Shazia, for joining us. I hope we will learn a lot from you regarding the CHD lab protocol. We have in panelist Dr. Ali bin Zubairi. Dr. Ali Zubairi is a professor of pulmonology and critical care medicine in Afghan University. And he's leading the interstitial lung disease and pulmonary hypertension clinic for the last 3 years. He's basically the director of this program. We will wait for him to join. Our next panelist is Dr. Waris Ahmed. Dr. Waris Ahmed is AKU faculty. He is an assistant professor and congenital pediatric surgeon at the Afghan University Hospital. Thank you, Dr. Waris, for joining us. And we are also waiting for you. We have just given you the call to join us. So this was our esteemed group of panelists. With the interest of the time, let's start with our first talk. Our first talk is by Dr. Nadeem Aslam. Dr. Nadeem Aslam is Assistant Professor of Pediatric Cardiology at the Afghan University and Hospital, Karachi, Pakistan. He has a special interest in adults' congenital heart disease with a special reference to issue related to clinical care in lower middle income countries. He is also establishing the first local catheterization-based pulmonary hypertension registry. Dr. Nadeem will talk about today on pulmonary hypertension national registries. Dr. Nadeem, over to you. You can please share your screen.
Thank you, Farhan, and organizers for including me in this session. Let me share my screen. Are you able to see my screen?
Yes, we are able to see you.
Yes.
Okay. So what I am going to discuss, I will be discussing various pulmonary hypertension registries which exist in high income regions and low income regions. So my talk will encompass the definition of registry, why registries are important even in our part of world, what are the various types of pulmonary hypertension registries which exist in both high income regions and in middle and low income regions. So far, what we have learned from these registries and the future and way forward. So by definition, registry is an organized system that uses observational study methods to collect uniform data relevant to clinical and other parameters in order to evaluate specified outcomes for a particular population. And this is usually defined by a particular disease, condition, or exposure. And that also serves as a predetermined scientific, clinical, or policy-making purpose. So why pulmonary hypertension registries are important nowadays? Because pulmonary hypertension is still considered an orphan disease. And in pulmonary hypertension world, randomized controlled trials are rare. So registries are a better way to define disease burden, both in terms of incidence and prevalence. What is the natural history of disease? What different types of or categories of or groups of pulmonary hypertension exist. They also help in identification of risk factors and assessment strategies and outcome based on these registries. They are also important to develop a health policy, particularly in high and low income regions. So they are a source of real world or real life practice. In addition to these factors, registries also put insight into increasing financial burden, and they help in pooling of data for advancing our knowledge relevant to pulmonary hypertension. And probably when randomized control trials are rare in pulmonary hypertension world, they are the best way to guide patient care. They are also helpful in detection of rare or late adverse events relevant to the treatment of pulmonary hypertension. So what most pulmonary hypertension registries provide? They provide demographics of patients. They give us insight regarding incidence and prevalence of disease in specific populations. They give us insight relevant to clinical and hemodynamic parameters and the various outcomes. Some registries also provide insight regarding various subgroups of pulmonary hypertension, the diagnostic delay which most of the patients face, and insight regarding pulmonary function test and treatment practices at various parts of the world. There are only very, very few registries which provide data on use of anticoagulants in different groups of pulmonary hypertension. And in fact, only one registry has included patients with pulmonary capillary wedge pressure of 16 to 18 millimeters of mercury. So if we see pulmonary hypertension registries in both high income regions and middle and lower income regions, there are a total of 17 registries which exist. Out of those 17 registries, 11 are in high income regions and 6 exist in middle to low income regions. So if we quickly see registries which exist in high income regions, these are the various registries. The journey started in 1980s, and up till now, there are almost 11 registries which are publishing or publicize data regarding various aspects of pulmonary hypertension. All these registries have shown that the incidence and prevalence has increased, and as the age of presentation. So these are the various registries giving important insight into various aspects of pulmonary hypertension in high income regions. All of these registries have shown that the incidence is increasing, as is the age at presentation. The first registry, the US NIH registry, the mean age of presentation was 36 years, but in current registries, the mean age of presentation has increased, and this is probably more related to the disease awareness. And among all of the registries, the female patients are more as compared to male patients. And at the time of registry or inclusion in the particular registry, most of the patients are in WHO functional class 3 and 4. Most of these registries have most of the patients with either idiopathic pulmonary hypertension or group 1 pulmonary hypertension. If you see registries from low and middle income regions, there are 6 registries which exist in middle to low income regions. The highlighted ones are those which include most of the groups of pulmonary hypertension, while rest of the registries only include patients with group 1 pulmonary hypertension. Almost all of them have shown that majority of patients are in functional class either 3 or 4 at the time of enrollment in these registries. And the survival rate is between 70 to 80% at 3 to 5 years. Very few registries have included pediatric population or population less than 18 years of age. So far, what we have learned from these various registries from high income regions as well as from middle and low income regions. So in terms of incidence and prevalence, the global burden of pulmonary hypertension is approximately 1%. And if we look at specifically patients with more than 65 years, the global burden is around 10%. No registry has shown the true incidence of pulmonary hypertension in pediatric population, but the incidence is reported to be 1 to 7.6 cases per million population in various adult registries. In terms of prevalence, there are up to 60 cases per million of adult population and up to 16 cases per million of pediatric population. Interestingly, 80% of these affected individuals live in developing nations. So if we look distribution of various subgroups of pulmonary hypertension in both high and low income regions, in high income regions, most of these patients belong to either left heart disease category or have pulmonary issues. While in resource limited settings, there are various other etiologies which contribute to significant percentage of these patients, including rheumatic heart disease, unrepaired congenital heart disease, various infectious etiologies like HIV and schistosomiasis, and various hematological disorders like sickle cell disease and thalassemia intermedia and major. This is an interesting chart. If you look at the figure which is above, you can fairly see in all over the world, whether it's high income region or low and middle income region, most of the patients with pulmonary hypertension are contributed by left heart disease, and remaining approximately up to 40% is contributed by lung disease. 5 to 10% is contributed by other etiologies. Now, if we remove this left heart disease and these lung disorders, then this is an interesting data from both high income and low income regions. You can see this green component of these pie charts, which is idiopathic pulmonary hypertension. So if we remove this left heart pulmonary hypertension due to left heart disease and due to lung disease, the majority of remaining patients belong to either idiopathic or heritable pulmonary hypertension. But specifically, if you look in African and Asian countries, up to 40% and 35% of patients belong to the group of unrepaired congenital heart disease. And many regions, especially Africa, some parts of Europe and some parts of Asia, the HIV and schistosomiasis related pulmonary hypertension is also prevalent, as the pulmonary hypertension related to hematological disorders like thalassemia and sickle cell disease. So distribution of pulmonary hypertension subgroups in various parts of the world is very different. Mostly it is either hereditary pulmonary hypertension, idiopathic, or drug-induced. But in middle to low income regions, the unrepaired congenital heart disease patients contribute a significant number. It is interesting to note from these registries that the risk of pulmonary hypertension immediately after shunt closure is reported to be 2.1%. And this is a late repaired lesions. And this incidence increases up to 15% at 50 years post-closure. Interestingly, ASD is supposed to be a very, very benign lesion before 25 years of age, but many of the registries have shown that the risk of pulmonary hypertension is at least 4% if ASD is repaired after the pediatric age, but before 25 years of age. So it is not that benign lesion. Many of the registries have shown that there are major differences in pediatric versus adult population. The adult Eisenmenger has better survival than adult idiopathic or heritable pulmonary hypertension. But when it comes to pediatric Eisenmenger syndrome, the survival is same as that of pediatric idiopathic or heritable pulmonary hypertension. And the sex ratio in pediatric population is more or less same as compared to adult, which are mostly female population. In pediatric population, again, group 1 pulmonary hypertension is more common. More than 50% are idiopathic or heritable, and more than 40% are related to other condition, in which the unrepaired congenital heart disease contribute approximately 80% of the population. The various registries have shown that in pediatric population, BNP and pro-BNP is done in approximately 25% of the population, and functional class is assessed by a 6-minute walk test or cardiopulmonary exercise test is only 38% and 7% respectively. So as we are progressing, we are seeing more patients with older age at the time of diagnosis, and they have more comorbids like obesity and other medical conditions. The older population have variable presentation and slightly different presentation as compared to pediatric population. They present with evidence of right heart failure like peripheral edema with less severe hemodynamic compromise and more limited functional capacity, while pediatric population mostly presents with either dyspnea or syncope. Since pulmonary hypertension presents with non-specific symptoms, and as I've just mentioned, dyspnea is the most common symptom, followed by fatigue, angina, dizziness, or edema, or symptoms and signs related to right heart failure. So we need specific and sensitized screening programs to diagnose these patients early in their part of illness. This is an interesting chart, which shows that there is approximately delay of 3 years between symptomatology and the patient presenting to any healthcare professional first time for evaluation of his symptoms. And when a patient presents to a physician for evaluation of his or her symptoms, there is a diagnostic delay of approximately 2 years before a diagnosis of pulmonary hypertension is suspected. And approximately the right heart cath is done after 5 years of initially becoming symptomatic. So this is the diagnostic delay, and this diagnostic delay leads to poor outcome overall. Because when the patients are diagnosed with pulmonary hypertension by right heart or in catheterization or invasive methods, the time has already gone. So overall, left heart disease contributes 60 to 80% of the disease, but this distinction is very, very important because of direct therapeutic consequences. And most registries have now decided not to include patients with left heart disease because of absence of efficient therapeutic strategies, especially in HFpEF group. Many of these registries have shown that more aggressive treatment approach is required. However, even most of them consider combination therapy in high-risk group. But many of the registries have shown that less than 50% of high-risk group patients receive combination therapy, and mostly they are on monotherapy. With respect to anticoagulation data, there is conflicting results and individual assessment is required, and more ICT randomized controlled trials are needed. Though overall survival is improving because of increased awareness of the disease and newer drug modalities, but the overall outcome is still poor. This bar diagram again shows various registries from high income regions, and you can clearly see 1 year, 3 year, and 5 year survival rates in various registries from high income regions. These same registries have defined various risk prediction tools in order to guide treatment modalities and improve outcome. And these are the various parameters which are included in various risk assessment tools. And 6 risk assessment tools exist currently based on various registries. So I'll quickly share our own data. We are trying to establish a local pulmonary hypertension registry, and it is a registry based on discharge diagnosis of pulmonary hypertension. From year 2006 to 2018, we have seen approximately 2,300 patients who have discharge diagnosis of pulmonary hypertension. And most of these are female patients, approximately 56%, 44 are male patients. Most of them are adults, more than approximately 90% more than 18 years, and 10% less than 18 years of age. We have seen various groups of pulmonary hypertension. 41% are group 1 pulmonary hypertension, 25% are undefined patient population, 18% are group 1 pulmonary hypertension, and rest are other groups, in which 12% are group 3 pulmonary hypertension, and 2% each group 4 and group 5 pulmonary hypertension. Overall, if we see the proportion of unrepaired congenital heart disease, it is approximately 10%. But if we see proportion of unrepaired congenital heart disease among group 1 patients, it is the largest group and contributes approximately 55% of the patient population. We have defined a new strategy to do right heart cath in these high risk group of patients who are mostly in either functional class 3 and functional class 4. They are unable to lie flat. So we use basilic vein approach to get invasive data on these patients. We have done up till now approximately 50 patients has undergone right heart catheterization by this methodology with no any reported adverse outcome. So we identify basilic vein by giving a contrast through a cannula in a peripheral vein, and then puncture this basilic vein. Advance a guide wire and a wedge catheter and take the hemodynamic data with no reported adverse outcome. And patient is ready to go home few hours after the cath. So what is the future? This is the future. Probably we need more robust screening methodologies, more robust diagnostic tools in order to diagnose these patients early. Probably personalized medicine is the way to go about in managing these patients. We need newer treatment modalities. So I'll stop here by showing my last slide, which is regarding area CV device, which is used in plan to be decrease or increase pulmonary vascular compliance in these patients. Thank you.
Thank you so much, Dr. Nadeem, for giving us a rich insight into the pulmonary hypertension registry, especially the local context. I actually, I'm very happy to see that we are participating in a lot in this, and we are actually gathering our own local data, which is the need of the time. And we are gathering the questions. If the participants have the questions, please send us to Salima Qurani to the chat box. Because we are already running short of the time, we should move to the next speaker, and we can actually have the discussion overall with the panels. Our next speaker is Dr. Leong. So Dr. Leong is a consultant pediatric cardiologist at the National Heart Institute of Malaysia. He specialized in adult congenital heart diseases. His interest is in pulmonary hypertension and congenital heart disease and heart disease in pregnancy. He has many peer-reviewed publications related to his fields. Thank you, Dr. Leong, for joining us today. And Dr. Leong will talk about the pregnancy in patient with the heart disease, especially the valvular heart disease management. Dr. Leong, over to you.
Thank you very much, Paula. Can you guys see my slide and can you hear me well?
Yes, we can hear you well, and we can see your slide as well.
Okay, perfect. All right. Good morning, good afternoon, and good evening, everyone. And my name is MC Leong, and I'm from Kuala Lumpur, Malaysia. All right. We know that as a woman undergoes pregnancy, there's a lot of hemostatic changes, and then some of it are such as increase in platelet adhesiveness, increase in coagulation factors, increase in the concentration of fibrinogen, and a decrease in protein S level, or increase in protein C resistance. And all these culminate to an increase in coagulopathy. Coagulopathy may favors pregnancy, but it doesn't favor pregnancy in mothers with prosthetic mechanical heart valve, because it increases propensity for heart valve thrombosis, a life-threatening condition which not only affects the mothers, but also the fetus. And the risk is present throughout the pregnancy until up to 6 to 8 weeks postpartum, which is the pre-puerperium period. If you look at the ROPEC registry, this is a registry which looks at outcome of mothers with pregnancy with heart disease. You can see that if a mother has a mechanical valve, the maternal mortality and maternal hospital admission has significantly increased compared to a mother with heart disease without a prosthetic heart valve. Similarly, if you look at the fetal wastage, which is defined by miscarriage less than 24 weeks or fetal mortality more than 24 weeks, if the mother has a prosthetic heart valve, the complication, the risk of fetal wastage is also significantly increased from 1.7 to 15.6%. So, but we know that all mothers are not the same. Mothers with different heart valves position, and even risk factors actually affects the risk of thromboembolism. For example, if the mother has a heart valve at the atrioventricular junction, for example, a mechanical valve at the mitral or the tricuspid position, the risk of valve thrombosis is higher than that of a valve at the aortic or pulmonary valve region. And also the first generation prosthetic valves, the ball and cage valve or the single tilting disc, actually has a higher risk of valve thrombosis compared to the newer generation of valves. And if the mother has other history of thrombosis, for example, a history of valve thrombosis, history of thromboembolism, or a poor systolic heart function, or is actively smoking during pregnancy, the risk of valve thrombosis is also elevated. So what do we treat? How do we treat it? We treat it, usually the popular choice would be warfarin. But unfortunately, warfarin crosses the placenta, and it causes embryopathy, especially in the 6 to 10 weeks. And we know that if we subject the patient on warfarin throughout the whole pregnancy, previous registry has shown us that the fetal wastage rate is about 6 to 6.4%. But we know that warfarin is more efficacious compared to heparin in thromboprophylaxis. But if you look deeper, you look at if the warfarin is less than 5 milligram compared to warfarin is at higher dose at more than 5 milligram, the things changes drastically. If you look at the risk, the estimation of live births with warfarin less than 5 milligram is 83.6. The fetal adverse event is 2.3%. But if the warfarin dose is more than 5 milligram, the live birth estimate is about 44%, and the fetal adverse event has increased about 6-fold. But what about heparin? Heparin is safe for not being able to cross placenta barrier, but the use of heparin is associated with increased risk of thromboembolic complications and maternal death. And when we talk about heparin, there are two choices of heparin, the unfractionated heparin and the low molecular weight heparin. The issue with heparin is there are many. For example, unfractionated heparin has to begin via intravenous route, which means that the mother needs to be warded during the administration of unfractionated heparin. And unfractionated heparin has notoriously noted to have increased risk of thrombocytopenia or heparin-induced thrombocytopenia. There are two types of thrombocytopenia in this case, the transient one or the late one, which is a bit more prolonged. And we also know that unfractionated heparin induces osteoporosis. And if the mother were to be given unfractionated heparin throughout the whole pregnancy, there's a reduction of bone density as high as 30%, and this predisposes the mother to vertebral fracture. And lastly, unfractionated heparin is not as efficacious compared to the low molecular weight heparin. If you look at low molecular weight heparin, it can be administered at home, has less risk of thrombocytopenia and osteoporosis, but we need regular monitoring. And this monitoring is not readily available in centers throughout the whole world. Only certain centers has the ability to monitor low molecular weight heparin trough and peak levels. And what about doing it without monitoring? We know that weight-based treatment is not reliable as the mother renal clearance and fluid distribution changes with pregnancy. And we know that as pregnancy progresses, we almost always need to increase the dose of low molecular weight heparin. So we actually need to balance a delicate, fine balance between the mother's safety and the safety of the fetus. On one hand, we have warfarin, which is safe for the mother and not so safe for the fetus. And on the other hand, we have a heparin, which is safer for the fetus, but not so safe for the mother. So what are the treatment options? We can give warfarin throughout the entirety of the pregnancy, or we can give low molecular weight heparin throughout the whole entirety of the pregnancy, or we can do something what we call a sequential treatment, where we give low molecular weight heparin or unfractionated heparin during the first trimester. Once the embryogenesis completes, we switch the mother to warfarin for the remainder, and at the peripartum period, we switch the mother back to low molecular weight heparin or unfractionated heparin. I like this cartoon picture because it sums up the risk perfectly, and I usually use this for counseling, pre-pregnancy counseling. So if you were to use vitamin K throughout the whole pregnancy, the risk of mother is actually very low at about 5%. The risk to the baby is about 35%. So accumulative risk to the mother and the fetus is about 40+%. But if we use low dose warfarin throughout pregnancy, the risk to the mother is about 5%, the risk to the baby is about 15%, and the accumulative risk is about 20%. If we use low molecular weight throughout the whole pregnancy, the risk to the mother is about 15%, risk to the baby is about 10%, and accumulative risk to both mother and the fetus is about 25%. What if we use sequential therapy? If we use sequential therapy using low molecular heparin, the risk to the mother is about 15%, risk to the baby is about 15%, and accumulated risk of 30%. Unfractionated heparin and warfarin combination actually has the worst of accumulative risk. The maternal risk is about 15, risk to the baby is about 30, so accumulative risk is more than 40%. So what does the guideline say? The American College of Cardiology says that if the baby, the mother is on the warfarin of less than 5 milligram, we can keep the patient on warfarin during the first trimester. Otherwise, we can either use low molecular heparin or we can use unfractionated heparin. After we have completed 12 weeks of pregnancy, we switch the mother to warfarin and daily aspirin. So at the peripartum period, we switch the mother back to unfractionated heparin to prevent intracranial bleed to the fetus and also bleeding complications to the mother. What about the European Society of Cardiology? It says that we can either use low dose warfarin or high dose warfarin throughout the entirety of the pregnancy, or we can use heparin, either low molecular weight heparin or unfractionated heparin. After 12 weeks, we switch the mother to warfarin, and if the mother has additional risk of thromboembolic complications, for example, atrial arrhythmia, smoking, then you start the mother on additional aspirin. Otherwise, we just keep the mother on warfarin. At the peripartum period, we switch the mother back to low molecular weight heparin or unfractionated heparin. But there's a caveat to this recommendation, because the recommendation is based on the available data and there's no randomized controlled trial data. And a lot of this data is sourced from case series, meta-analysis, and we only have a recent ROPAC registry. And importantly, it did not take into consideration the uniqueness of the treating facilities, what facilities available, what kind of expertise available, and the uniqueness of the patient. What I'm trying to emphasize is that I would like to emphasize is care does not start after the mother is pregnant. In fact, it starts way before the mother gets pregnant. It's about when the mother needs a valve, we have to select the valve together with the parents, the potential mother. We have to, just before pregnancy, we have to sit down together with the husband and wife, do a pre-conception assessment and counseling, and then we need to detail out the anticoagulation plan during pregnancy and have a multidisciplinary team to manage the intrapartum and postpartum care. And lastly, after the baby is delivered, we need to talk about contraception post-delivery and also talk about the planning of the next pregnancy. So I'd like to take a couple of seconds talking about selecting the right valve for the right patient. We know tissue valves last for about 8 to 10 years. There's no need for anticoagulation, and in fact, it's the safest valve for mothers to have during pregnancy. We don't need much monitoring, and there's not much complication to talk about. Whereas mechanical valve typically last more than 20 years, but we need to be wary of this anticoagulation, especially during pregnancy. So the question that we often ask ourselves is, when we want to implant a valve, is how long after the valve replacement will the patient get pregnant? If the time duration is about 1 or 2 years, then we'd like to choose a tissue valve when you implant the valve. If it's going to be more than 10 years, then we would like to choose a mechanical valve. So a very important concept I want to bring across is preconception assessment and counseling. We'd like to assess before the mothers actually get pregnant, how's the valve? Is it functioning well? Is it thrombose, whether it's valve stenosis, and then whether it's Parnus building up the valve. And then we would like to meet up with the husband to discuss the anticoagulation options during pregnancy and the risk involved, so that we align expectations and we get everybody on the same page. Third thing is, want to find out how much warfarin this patient's on and what is the usual INR reading. If the patient is on 5.5 milligram, which is not too far off from 5, I would ask the mother to try to reduce the warfarin by having stringent control of the diet. If you can bring it down to less than 5, then I'm more than happy to keep the mother on warfarin throughout the whole entirety of the pregnancy. And then lastly, I would like to emphasize the importance of a planned pregnancy. As most teratogenic period is 6 to 10 weeks, we certainly do not want the mother to present at 10 weeks and say she's pregnant at the time and she's on high dose of warfarin. I also like to explore whether the mother is actively smoking or indulge in recreational drugs or has any other risks of thrombosis. And this would influence my decision making in selecting what kind of anticoagulation the mother should be on. So in short, anticoagulation actually depends on your facilities and your expertise. But generally, if the warfarin dose is lower than 5 milligram daily, then people tend to generally like to continue with the warfarin throughout the pregnancy. If the warfarin dose is higher than 5 milligram, then we want to look at whether is it possible to introduce low molecular weight heparin. Because if you introduce low molecular weight heparin, you need to monitor anti-factor 10A. Not only do you need to monitor it, you need to get the results fast, because you need to act on the results as soon as possible. If it's not possible, then I will stick the patient on unfractionated heparin until the week the patient has completed embryogenesis. So if you want to keep the patient on low molecular weight heparin, we need to monitor the patients 2 weekly and make fine adjustment. After 12 weeks, we keep the patient on warfarin until the baby is almost 38 weeks and we're preparing to deliver the baby. So intrapartum, what we usually do over here at our center, we would omit low molecular weight heparin 12 hours. We would, if the baby mother is on unfractionated heparin, we will omit it for 4 hours. And we want to make sure that INR is less than 1.5. But what happens if the mother goes into premature delivery and the mother is still on warfarin? Then it would entail massive blood transfusion and an emergency C-section. Then I would like to talk about the benefit of inducing vaginal delivery and induced vaginal delivery versus elective C-section. And if we want to do a spinal epidural anesthesia for this patient with an anticoagulation, it need to be performed by an experienced anesthetist and not by the junior-most anesthetist. So we'd like to give a contrast of the benefits of inducing SVD and versus elective C-section. When we first started off this program, we used to do elective Caesar because we like it, because it's more planned environment, and then there's no issues whereby we induce and then the os is full at 3 a.m. in the morning. And then at that time, our obstetricians prefers to do day procedures because they like it when they are fresh. And then, but then we encounter high risk of rebleeding, especially at the uterine wound. So we urge you that if you want to do elective C-section, especially when you reintroduce anticoagulation, if the mother complains with abdominal pain, even you do not see any active bleeding in the skin, do think about uterine wound bleeding. You may need to go in and then secure the wound. In this case, it might be prudent to start warfarin later. You keep the patient on low molecular weight heparin, which has a low tendency of bleeding. You may want to delay initiation of warfarin about 2 weeks later when the wound is a bit more healed. But I would generally advise people to go against this idea if the valve status is not good. For example, if there's stenosis and the valve, there's flow acceleration across the valve, then you know that there's very, very high risk of it thrombose when we induce the mother and then the mother is without anticoagulation for a long period of time. So if you look over the practice that we do right now, we commonly practice right now, nowadays we like to induce SVD in this group of mothers because there's less risk of bleeding. We have no risk of bleeding at the C-section wound. We can initiate warfarin early and get the mothers home as early as possible, or even mobilize the mother as soon as possible. But then we require obstetric service to be round the clock, which means that if the full OS is full at 3 in the morning, the obstetrician will have to come in the middle of the night and deliver the mother. And also, we always want to make sure that the valve status is good before we decide whether we need to induce the induced vaginal delivery in this group of mothers, or we decide on C-section. If the valve is quite risen, there's not much flow acceleration across it, the valve is functioning well, then we'll be more happy to induce vaginal delivery. Postpartum, we need to make sure the patient has contraception before discharge. In our center, we prefer Implanon, and then but in some centers they prefer Depo-Provera. And then we have to emphasize the importance of planned pregnancy. So it's about education, communication, and education and communication. And we need to reassure the mother that warfarin is not contraindicated for breastfeeding, and they can freely do so. There's no precaution to be worried about. What about the new novel anticoagulant, which is Xarelto, for example, the Dabigatran? What is their role in pregnant mothers with prosthetic valve? I would like to share with you the outcome of this study, which is used for patients without pregnancy. It is a head-to-head comparison between Dabigatran efficacies between the Dabigatran and warfarin. It's a multi-center phase 2 trial and open label with 2-to-1 unblinded to Dabigatran and warfarin, and they were given for 12 weeks. And this study was prematurely terminated because of high rate of complication. Let me show you the data. So if compared to Dabigatran, warfarin has a high rate of event-free of thromboembolic event. So warfarin, in short, has low risk of thromboembolic event compared to Dabigatran. And then warfarin is known to have lower risk of bleeding, first bleeding, compared to Dabigatran. So in short, warfarin has a lower probability of thromboembolism and lower probability of bleeding. So it is safer compared to the NOACs, and that's why NOACs has not been recommended as a standard treatment of choice for patients or even pregnant patients with a mechanical prosthetic valve. Importantly, NOAC also crosses the placenta, and the potential for embryopathy is present. So what does the future hold? The future is quite promising. Some people, they feel that if I were to have a valve replacement, I want to challenge a woman and find out how much the warfarin is required before I even decide on what valve I want to put in. For example, if before you put in the valve, you put the patient on warfarin, and you find that the warfarin requirement is about 4 and 3 milligram. So you know that this patient can do well even with a mechanical valve. So, and there's another promising thing about newer heart valves, which requires a lower INR. For example, an Onyx valve. Onyx valve is a newer generation of valve whereby the leaflets open about 90 degrees and thereby decreasing the flow turbulence across the prosthetic valve. Therefore, we need a lower INR level, and this translates to a lower level of lower dosage of warfarin required. And therefore, if you implant these valves, hopefully we can reduce the warfarin requirement, and more mothers can undergo pregnancy with warfarin throughout the entirety of pregnancy. And importantly, we have good results with valve repair. We know that valve repair is not a problem for mitral and tricuspid valves. Aortic valves always poses a challenge, but nowadays we have a new type of repair called Ozaki repair, which is the marsupialization of the aortic valve using pericardium, and the result is fantastic. So this leaves us with another option to mothers who are at their reproductive age. So if you would ask me this question, is pregnancy safer now than before? I would say it's a resounding yes, because we have newer technology, newer valve technology. We can monitor, we have better tools to monitor our, for example, low molecular weight heparin. We have a better control, better grip of the warfarin and monitoring of low molecular weight heparin. And importantly, we have introduced pre-pregnancy counseling to align the expectation of the mother and the husband, so that the compliance towards treatment will be better. So this is my last slide. In summary, I would like to say that pregnancy in mothers with mechanical valve is challenging. Not only is the treatment challenging, handling of the patient and the family members requires a lot of patience. I would say a lot of patience, a lot of counseling, and a lot of reassurance. And the actual care actually starts way before pregnancy. It starts at the time where we select the valve for the woman who's going to be pregnant. And then pre-pregnancy counseling and assessment is important to align patients' expectation. And there's actually a no one-size-fits-all treatment regime. The treatment should be individualized to the patient and individualized to the treating centers. What is good for one center may not be the optimal, the best for the other centers. And you need to know what works best for you. And you need to have a core team to help you manage this patient. And remember that this treatment is a marathon. It's not a sprint. We're talking about a 10-month pregnancy. And when in doubt, always seek help. With this, I thank you for your patience.
Thank you so much, Dr. Leong, for such a nice and comprehensive talk over management of patient in pregnancy with valvular heart disease, especially the mechanical. And we have a couple of questions with you. I actually like your last slide that if someone asks you about the pregnancy is safe in the patients with mechanical valves, so yeah, it is now relatively safe with the new techniques and the improved management. Now there's a question by in the chat box. One of the question was regarding the use of the NOx data in the pregnancy that has been answered by you. One of the question is the use. Is there any data on the use of the onyx valve? Because we all know that it has a lower target for anticoagulation. And the second question is if the onyx is at the mitral position. I would like to ask Dr. Annie Mary, if she can put some light over and want to comment. Dr. Annie, can you just would you please like to comment? Is there any data on the use of the onyx during the pregnancy? And
Sure.
because it is the dose of the warfarin is also important. It's not only the INR, it's the dose that actually ask us to just hold ourselves for using warfarin during pregnancy.
Yes, thank you. First, just a wonderful talk, Dr. Leong. Thank you for that. It brings up so many of the challenges that we deal with when we are caring for women with valvular heart disease in pregnancy. I think there are now limited reports and series of the newer types of valves, such as onyx valves, with some favorable outcomes. But the take-home message with that is that nothing is completely safe. And whether it is someone who's had a valve repair or a replacement, just pregnancy in of itself has a certain risks that come up with it. So we need to be aware of that. So I am personally not reassured by the type of valve. And just to say that, yes, I'm hopeful that some of the newer generation valves will be more effective and less risky. But women and their partners have to understand that it is a big undertaking to get through a pregnancy with any type of mechanical valve.
You are absolutely right. It's always a challenge to treat pregnant ladies with mechanical valves. So with the interest of the time, I would like a humble request to all the speakers that we are actually ahead of the time. So let's, without taking a lot of time, let's move on to the next speaker. And our next speaker is our very own, our AQ alumnus, Dr. Ali Zaidi. I have actually already given introduction of Dr. Ali Zaidi because he's one of our panelists also. So Dr. Ali, you are welcome here. Just please move on. We are actually waiting to hear you.
Thanks, thanks, Farhan. Can you see the slide?
Yes, we can see the slide and we can hear you clearly.
Perfect. Thank you. Thank you for having me. And you know, I have to say, you guys have put a great conference together. It's great to see some friends, both from here in the US and also in Pakistan. So I'm going to spend the next 15-20 minutes. I'll try to go quick. What I was asked to do was to talk on something that's very focused pulmonary hypertension and congenital heart disease, and to give evidence as to how we approach it. So I'll give you a bird's eye view, and I'll take it sort of simply through the definition of PAH, a little bit of background. Nadeem has already talked a little bit about it, the epi, and then we'll get into how we prognosticate, classify, and how do we manage patients with what we call pulmonary arterial hypertension, congenital heart disease. So here's the definition, and this has been discussed for PAH. This is not just congenital heart disease. And the bottom line is that when we think of pulmonary arterial hypertension, what we're saying is that the mean PA pressure is elevated. That number has debated. This pendulum has swung. It's been more than 25. It's been 20. More recently, they've been pushing for 20. But you got to keep the wedge down, which is left-sided pressures, and the PVR has to be high. But the bottom line is that whichever way you get there for pulmonary hypertension, the bottom line is that there is an increased pressure load. The right side, the right heart is seeing more pressure, and that is where the troubles are will arise. So what does this mean from a background standpoint? Well, as Nadeem was saying, that this is a rare disease. I struggled sometimes with congenital heart disease and PAH just to give true numbers, because even in the United States or in the Western world, it affects a tremendous amount of people. So up to 50 million people have PAH, but within that realm lies congenital heart disease. Now, keep in mind that a lot of these patients start in the 4th and the 5th decades. A lot of them are women, but a lot of this is autoimmune conditions. That's where the data came from. But in this realm is congenital heart disease. This is what Nadeem just showed on the right of the panel is our own Babar, who's clearly a star. He's been doing this for a while. But what this shows is the prevalence of pulmonary hypertension in the rest of the world, in the developing world. And in this, once again, lies PAH within the realm of congenital heart disease. To get granular, and Nadeem's already done that, I won't go there. But the point being that it's prevalent. It's prevalent here in the developing world. It's prevalent in the rest of the world. But let me take you a little bit back in history as to, well, how did this start? Where did the concept of PAH in congenital heart disease start? So if you look at this is in 1946. This is in a dog model looking at atrial septal defects, and they showed. And again, this is in the 30s and 40s, where really the realm of the field of congenital heart disease really is now beginning to take its own form. Surgeries and catheterizations really haven't taken off. But what this shows you is that they were talking about pulmonary hypertension in dog models. But what I really found interesting in this was that the first reference, the only reference in there is from Helen Taussig, and those of us who do congenital heart disease and know pediatric cardiology, that she is really one of the founders and really the mothers in congenital heart disease. And her first paper was 1938. So that's when people started talking about it. So what does it mean in this day and age? In the 1960s, there's another paper that showed that patients with congenital heart disease, as they get further along, if you look in this, and they still had pulmonary hypertension, they had PVR development, and this is certainly something that was recognized. So the pathogenesis in congenital heart disease for PAH was recognized in the 40s and the 50s and the 60s. What does it mean now? And this is data from Europe. This is Dr. Mahadevan, who's now at UCSF, and he had a very nice paper talking about the prevalence of pulmonary hypertension in exclusively congenital heart disease. And you pick any lesion, you pick atrial septal defect, a VSD, an AP window, you can see that there is some element of pulmonary hypertension in any congenital heart lesion that you pick that has a shunt associated with it. And we'll get into a little bit of a description as to what this means. Now, as far as classification goes, there are several classifications. I tend to like this one only because it breaks it up, as we all know, in the 5 groups. And this is across pulmonary hypertension, so the whole gamut. So group 1, as Nadeem was talking about, group 2, which is left heart, group 3, that is lung disease, 4 is chronic thromboembolic, and 5 is everything else. But really where we will focus on is here, which is group 1, where we get into congenital heart disease. And that's really where the shunts are coming in. So keep this in mind. We're going to focus on WHO group 1 in CHD PAH. So what does this mean from a prevalence standpoint? Again, we look at the data for PAH in developing countries, WHO group 1, the most common is connective tissue disease. Congenital heart disease is rising. It's now being recognized, and it's being recognized in the last 15 years. But when you look at this, it's still connective tissue, is autoimmune, scleroderma. But in congenital heart disease, there is now a recognition that we have to think about them as either shunt lesions that are either surgical shunts or unrepaired shunts, but they can lead to pulmonary arterial hypertension. So clearly, the data is there. What does it mean? From a progression standpoint, it doesn't matter how you get there for pulmonary hypertension. This is just time course. And what it shows you is that as your PVR, your pulmonary vascular resistance, starts going up, your PA pressure is going up, but at some stage, your cardiac output will start to fall. And what that really means is that, again, it doesn't matter how you get there. When the PAH is high enough, the PVR is high enough, the right heart will start to suffer and your cardiac output will drop. And at the end of this is mortality. PAH is a disease that will lead to death. But when you look at the evidence for mortality and the survival by age, this is just to show you that you break it down. This is congenital heart disease. This is connective tissue HIV. Excuse me. What it shows you is that if you treat congenital heart disease and you get them through the initial stages, the outcomes for congenital heart disease or PAH and congenital heart disease is actually better when you compare it to line item with connective tissue disease or autoimmune disease. So the point being that yes, it is there, the prevalence is there, but if we can manage it, then the outcomes are better when we compare it to the other etiologies. This is just to tell you the right heart catheterization. Barbara brought up a question yesterday, where we were talking about PH in another session. And right heart catheterization really is your gold standard in congenital heart disease. I cannot drive this point home. Certainly imaging is the crux of congenital heart disease, but when it comes to PAH, your right heart is very, very important. We look at the defects, we look at QP, QS, we look for left-sided disease, vasodilatory challenges, we'll get into that in a second, and then the hemodynamic parameters. So keep this in mind. I'm going to come back to this slide. This is from a few years ago, and why the right heart catheterization is so important. I'm going to walk you through this just as a prelim, but I'll come back to this. What it's telling you is that if you suspect somebody having some sort of congenital heart disease with a shunt and pulmonary hypertension, you will do your hemodynamics, you will look for the QP, you look for the QS, and then based on what you find where your PVR falls, you can go straight to operation or surgical repair, or you may have to go into what's called vasodilatory testing in the cath lab. Based on that response, you can then decide if you want to do targeted pH therapy, you follow them down the road, and then you decide if they need to be treated. So there are those patients with shunts and pulmonary hypertension, congenital heart disease with low PVR or very high PVR, but there is a gray zone, and we will get into the evidence for this as to how we should manage this. This is a very important slide showing you risk assessment when it comes to patients with congenital heart disease and PAH. And very, very simply, I'll break this down. There's low risk patients, there's intermediate risk patients, there are high risk patients. And on this column that you see, we look at multiple different parameters. They can be symptoms, they can be testing, they can be lab work, there's imaging, and there's hemodynamics. And each one of them gets granular, and based on what you find, then we risk stratify each patient. It doesn't matter, again, what the lesion is, but this is how we look at patients with congenital heart disease and pulmonary hypertension. That's how we will risk stratify. I will come back to this in just a second too. The bottom line is, what are we trying to do? So we look at them, we look at the evidence, we look at prognostication, but this is what we're trying. We're trying to improve quality of life, improving walk distance, we're improving hemodynamics. Can we bring symptoms down? And that's really the goals of treatment, which then brings me to, well, what are the targets? What treatment targets are we going to get at? And what this means is really this slide from New England Journal. This is one of my favorite slides in pulmonary hypertension, is that the three pathways, endothelin, nitric oxide, prostacyclin. I will not get granular into this, but the bottom line is we want vasodilation in the lung vessels, in the pulmonary arteries. We do not want vasoconstriction. Bottom line, vasodilation is good, vasoconstriction is bad, and we have to get there somehow. And when we get there, this is what we're using. We're using calcium channel blockers or ERAs or phosphodiesterase inhibitors, the newer drugs that are out there, and then prostanoids. Now, I understand that in the developing world, we certainly don't have many of these drugs, but even in the Western world, these drugs have really come into the market over the last maybe 15 or 20 years. But now we have drugs. We can use drugs when it comes to pulmonary hypertension. The drugs can be single or they can be combination. But the bottom line with PAH is that nothing makes sense when you go solo. You've got to bring in combination treatment. So keep this in mind also as we go into this. This is a slide from the American Heart Association. I know it's busy, but don't worry about it. All I'm trying to show you here is that you have a patient, you cath them, you look at the hemodynamics, and then you risk stratify them as we were just talking about. And based on the hemodynamics, we figure out which drugs we're going to use. It's going to be single, it's going to be dual agents, more than that. We follow them, and then we look at investigational protocols. Don't worry about this with the slide. The point is combination treatment is really what we're looking at. So what does this mean? So what we're talking about PAH, congenital heart disease, right? So the question is, well, show me the PAH, congenital heart disease. Well, I'm going to walk you through a case. But before that, this is how I look at it at every single patient with congenital heart disease and PAH. And I think this is a good way to look at it, is that you look at the type, you look at the clinical classification, we risk stratify them, and then we decide therapies. And it was a four-pronged approach. When you look at the type of congenital heart disease and shunts, it's very simple. We look at intracardiac shunts. This is just a slide showing all the different types of atrial septal defects. This is ventricular septal defects. These are extracardiac shunts. So for instance, total anomalous veins certainly was repaired. And then surgical shunts, which are multiple different types. So we have to identify what sort of lesion we are looking at and what that means for each patient. That's number one. That's the first thing we have to do. Here's the case. I'm going to walk you through this. This is someone I saw recently, a 28-year-old young lady, shows up with progressive shortness of breath and fatigue, no hospitalizations, played sports. She's able to do her activities, but now she is taking longer to do her activities, no syncope. She was recently told that the heart is enlarged. Initial signs, vital signs, blood pressure is okay, a little bit on the higher side, not too bad. Heart rate's okay, 95%. She's got a loud P2, lungs are clean, creatinine's okay. Hemoglobin is roughly running a little bit on the higher side, which is a little surprised to see, but her BNP is 56. So we've got some basic labs. Here's the echo. Right heart is on the right side. This is the left side. So you can tell that the right atrium is enlarged, the right ventricle is enlarged, but overall the systolic function is okay. She had TR, and her TR velocity here was about 3.8. And then this is a subcostal imaging. We couldn't see the defect initially, and I know Anne-Marie is on as one of the panelists. You see this defect that you can see is a very high anterior superior atrial septal defect. Almost made us think if it's a superior sinus venosus, but it wasn't. The pulmonary veins are coming back normally. So clearly a moderate sized atrial septal defect. This is something that we saw. Pulmonary arteries are enlarged. This is the right and the left pulmonary arteries. So we can tell that this patient probably has pulmonary hypertension. She's had it for a while. And then this is the pulmonary valve showing you there is mild pulmonary regurgitation, but the end diastolic Doppler gradient of the PR jet is elevated. So again, it tells us that the patient probably has pulmonary hypertension. So the bottom line is you've got RV enlargement, there's no RV alpha tract obstruction, there is normal LV size and function and elevated PA pressures. We follow this up with an MRI. And again, on the right side of the screen, you can see this is an off-axis view, but what you'll see here is this is the atrial septum. You can see the atrial septal defect. And the idea was to quantify and look at the right-sided chamber sizes, RV, EF. Our EDVI came at 154. The EF is 46%. On the right side, it's 62% on the left side, and the PAs were enlarged. So this is where the catheterization comes in, and I'll walk you through this, is that the the PVR was 5.9, it's elevated. The QPQS is 1.8 to 1. And here's where the acute vasodilatory testing comes in. We cath her, we put her on FiO2, put her on nitric oxide, didn't change a whole lot. Did change some, but did not change a whole lot. Went from 5.9 to 4.1. The QPQS didn't change a lot. But the point is that we were still going left to right. We're at a stage where we haven't really reversed her shunt flow. This is her hemodynamics, and this is again the crux in pulmonary hypertension. We look at saturation, she's elevated. RA-RV is 80% on the right side. She's 100% in the LA. She's 98 in the descending aorta, but her mean PA pressure is 56. Her left-sided wedge pressure is 8. So again, this is purely pulmonary arterial hypertension. And then once we vasodilate, it didn't really change a whole lot. So again, we're staying with a left to right shunt. PVR is high, PA pressure is high. So again, the crux becomes hemodynamics and understanding what those numbers mean. So what does this mean? Well, now we have the hemodynamics. When you look at the data out there, well, what do we do with this now? Well, this is from a few years ago, and again, European data from the Brompton. And what they said was, if your PVRI is 4, you're fine. You can go ahead and close it. If it's very high, if you're very high, and this is index body surface area, don't close it. But there is a gray zone here where you could sort of figure out how you want to handle these patients. I mean, they're in that gray zone territory. Take you back to this slide. And again, this is, if you stay here, this is where we're at. What we're saying is we found a lesion, we found pulmonary hypertension, we cath the patient, these are your hemodynamics. This patient is following where? She's following probably somewhere along this category. She's probably on the higher side. We acute vasodilatory tested her. There is some reaction, but not a lot, but the chances are we're probably going to use some pH therapies. So now what? So now what do we do? Should we use pH therapies? And what is the evidence for this sort of gray zone that we get into? Well, there are several studies that have come out, but this was one that we were involved with. And this was led by Alyssa Bradley at Ohio State. And this was through the ARC network, 13 centers. We had 69 patients. And what they showed was that if you look at unrepaired defects and repaired defects, these patients were unrepaired from the start, went on pulmonary vasodilators. They were thought to be unrepairable, and they were followed in 2 points in time, 6 months and then a year. And what you can see here, the 6-minute walk, is that those all unrepaired initially got better with pulmonary vasodilators. The 6-minute walk test got better. Their resting oxygen saturations got better as well, and they were eventually taken for repair, and they actually did very well. And the projected survival over 10 years was that if you treat these sort of gray zone patients, the chances are that they can probably do well over a long period of time. And there's a lot of data that is now arising for it. I'm not saying that this is across the board, but this has to be very carefully thought. So the question then comes is, well, what do you use? What is out there? There are many drugs out there. So if you think about it, you can choose ERAs and PD5s. I know this gets granular, and I'll walk you through this in a second too. The plethora of drugs that can be used in the developing world, or you could leave them and say nothing, or you could say I can do surgical repair. Well, what's the evidence? Well, this is where the clinical classification comes in. You have Eisenmenger syndrome, you have small defects, and then there's PAH after defect correction. And for the lack of time, this is where we're going to stay. This is PAH with left to right shunts. And this is what our patient had, and that we're not in Eisenmenger territory. This is not a small defect. The patient's not been repaired, and this is how you clinically classify somebody who has CHD PAH. So what do we do? Well, same process again. We walk this patient through each of the principles that we had initially outlined, and then said, well, what is a prognosis? What is a 1-year mortality when you look at clinical signs, testing, imaging, hemodynamics, blood work? Where does she fall? So if I take her back, and the same slide I showed you, and we put her hemodynamics and clinical parameters, she is falling in a low to intermediate risk category at a 1-year prognostic mark. So she has some features of intermediate risk and some features of low risk. She's certainly not high risk at this point in time. So what's the evidence? What guidelines are out there? So again, in the last 10 years, there's been a tremendous push to say, well, how should we treat them? Starting in 2009, then 2015, there's data from the Canadian Society, from the CHEST folks. There's actually a wonderful paper in PAH, CHD in children. So there's a ton of data that is coming out of the last 10 years as to what guidelines are out there. So again, going back to this again, a lot of this comes from the guidelines and the data that Alyssa Bradley has put together, is there are several drugs that we can use. But what I want you to focus on is the functional class, that these drugs, ERAs, PD5s, PCAs, all these drugs are out there, but which one do we use? And the bottom line is that you can use any one of them. When you look at the guidelines, you have to determine the prognosticated risk, which functional class the patient is, and are you going to use monotherapy? So our patient was a low to intermediate risk, functional class 2. We could probably pick monotherapy. If we took monotherapy, we could use an ERA, a PD5, or an IP agonist, or you can go down and say that she's a low to intermediate risk, more towards the intermediate risk side, still functional class 2, and we'll use combination drugs with the ERA PD5. So there is data. We're using evidence to guide our therapies at this point. So we go back to her. This is where she's at. We've gone through this a little bit. This is where she's following, low to intermediate risk. And this is where we will simplify it. She's not high risk, so we're going to take away the column on the right. We're basically going to say that this patient, based on the evidence that's out there, could either go down an initial monotherapy route or an initial combination therapy route. She's not Eisenmenger's. She's probably a prevalent left to right shunt. This is not a small defect. So the chances are you could probably get away by using combination drugs. So what we ended up doing was taking her and putting her on an ERA and a PD5 based on the evidence that's out there. So this is where she falls into. So the bottom line is that, and I'll end here in 30 seconds, is that PAH-CHD is certainly something that's it's out there. It's been talked about since the 1940s, but it is a complicated disease process. It cannot be diagnosed by imaging alone. Imaging is a crux of congenital heart disease. But right heart catheterization is the gold standard when it comes to pulmonary hypertension. There are therapies. It is a progressive disease. You can be single, combinational. I didn't get into long-term sequential care. And then if none of this works, then you have to get down the route of transplantation or surgeries. And again, that becomes a little more granular. So I'll end there by thanking everybody and allowing me the time to take this on. Sorry if I went too.
Thank you so much, Dr. Zaidi. You are absolutely on the time. So thank you so much. There was an excellent discussion going on between our expert, Dr. Babar and Dr. Shazia and Dr. Nadeem. I have a question because you talk about the right heart cath is a gold standard. That is okay for the higher income countries, but when we talk about the lower middle income countries, especially, I think Dr. Babar can actually add this, and of course, especially in the private setups, the right heart cath used for the risk stratification is usually a costly thing that we are offering to the patient. So, what do you think if I ask you, okay, what is the best in the imaging? Like you talk in the last slide that imaging is very important for that. So what do you think, what imaging modality in your experience is remain the best surrogate to the right heart cath? And then I will definitely request Dr. Babar to talk about his experience in from lower middle income countries also, because of course the echo, the CMR, the CT, there are the modalities. So what is your experience, and then from the higher income countries, and then Dr. Shazia and Dr. Babar for from the lower middle income countries?
Yeah, so thank you. So that's a good question. So you have Anne-Marie Valente on the panel too. I mean, Anne-Marie is a leader in congenital heart disease imaging, and you should probably bring her into this too. I shouldn't be speaking about imaging in front of Anne-Marie, by the way, but I will say that. So when it comes to pulmonary hypertension and congenital heart disease, I mean, our go-to, the first modality has to be echo. That's where you have to start. You can't go to an MRI or a CT as your first modality tool. It still has to be echo. What I will tell you is that, sort of wearing my imaging congenital heart disease hat on, the way we look at imaging for the right heart as a congenital imager is a little bit different than if it was just somebody who's out in the community doing an echo in the clinic as an adult cardiologist. And the point I'm making is your gold standard will still be, or your go-to study will still be an echo. We then go on to MRIs and CTs when we need to, but it's not our first line. But that's really it. I'm going to hand this to Anne-Marie, because really this is something that you should bring her in.
Thanks, Ali. Terrific discussion and great talk. I would agree that echo is where we start. I think there is no replacement for invasive measurements, and as hard as that is, and our first speaker, Dr. Aslam, mentioned it's about 5 years by the time some people that have PH are actually diagnosed and get to cath, and that's a huge issue. So I would say that all of the imaging modalities are good when available, but getting someone to get invasive hemodynamics is really the gold standard that cannot be replaced, no matter how good we think the imaging is.
Okay.
Add on to Dr. Zaidi, this is Shazia. So what he said, that imaging is the crux. Maybe we can diagnose the patients who need right heart cath. We can filter those cases. And then, of course, the diagnostic gold standard is cath, of course. We can follow them serially after the cath, but the gold standard for diagnosis is cath for sure.
Right. Absolutely. I think so. And I don't want to delay this, but I agree. I think imaging is where you start, but your management and your prognostication will come from catheters. And in the slides I showed, when you look at the prognostication for 1 to 2 years, you're taking in everything: clinical, lab, echo, or imaging, cath. So prognostication is an amalgam. It's not just a one-stop shop.
Sure. Thank you so much for the discussion. So I actually got the message from the organizers that we are adding a lot of time. So let's move on to our next speaker. Thank you so much. It's an interesting session, and actually I want to stay here for a longer period. Our next speaker is Dr. Mahim Malik. She's already starting sharing her screen. Dr. Mahim is a US board certified congenital cardiac surgeon, and currently she's a section head of cardiothoracic surgery at the Ahmed University and Hospital. Dr. Mahim is an AKU alumnus from the class of 2007. She received her training in the US and returned to her alma mater in 2017. Her area of clinical interest is neonatal cardiac surgeries. Interestingly, and the most important thing is Dr. Malik is also founding member and general secretary for the Association of Women Surgeons of Pakistan. Thank you, Dr. Malik, for joining us. And you can start. We can see your screen, and we can actually see you also.
Great. Thank you so much, Farhan, for giving me this opportunity. I'd also like to thank the conveners for giving me the opportunity to talk in front of such an esteemed group of people. I actually did not have any disclosures for my presentation, but after listening to the first couple of talks, my only disclosure is going to be that you now have a surgeon presenting. So bear with me if it sounds a little simplistic, and you already know all of this from before. So I'm just going to go ahead and start. So as we all know, adult congenital heart disease presents a very complex group of patients, which is highly heterogeneous, and it's a group that's constantly evolving. According to the Bethesda, in 2000, it was estimated that there is about 2,800 adults with CHD per 1 million population, and that group is constantly evolving. One of the reasons why it's changing so fast is because of the management and outcomes of CHD in infancy and the neonatal period have changed. Also of a particular note is that there's a significant difference between ACHD in the developed world and the LMIC. So I think half of our panelists will have a very different concept of ACHD from the other half, just because their experiences are so different. And for me, this is particularly important because when I was in training, ACHD meant something very different to me than what I saw over here. And this is of particular interest to me and kind of close to my heart now in the 3.5 years that I've been in Pakistan, is primarily because of the first time you see an adult with an unrepaired cyanotic heart condition, you're that's an eye opener. And then the first time you do a Glenn on a 25-year-old, that also is I would say it's also a life-changing experience, because throughout my training and while I was in the US, you'd never actually imagine doing a Glenn in somebody of that age. So that in particular, so ACHD in particular holds a lot of interest for me. Some of the challenges that and again, this presentation is kind of personal, like I said, because of my experiences. So in my eyes, there's significant difference in the challenges that we face regarding management of ACHD patients in Pakistan. There's a significant burden of unrepaired disease. that we see over here, and that just really changes how we manage these patients. What we've seen, and other centers have reported also, that they have longer hospital stays, and some of this is due to the consequences and the sequelae of the unrepaired disease, such as collaterals, RV dysfunction from long-standing hypoxia, and long-standing cyanosis, and these also lead to more post-operative complications. Another thing that Dr. Laila Ladak is going to talk about in more detail is that all of these things have significant effect on their long-term quality of life and how they perceive themselves. And there's a significant burden that this places on their social and psychological outlook on life as well. Which a lot of times when we talk about outcomes, we never really take that into effect. But you talk to somebody who's been walking around with the saturations in the 60s and the 70s for most of their life, and you realize that they've had significant compromise in their quality of life, and it was just something that they were just living with and just didn't know that things could actually be better than they were. Another thing that's really important is that there's not enough centers over here that actually deal with ACHD. So fairly frequently we'll see adult patients who had their lesions repaired by adult cardiac surgeons, or have been seen, by no offense to anyone, have been seen by adult cardiologists, and a lot of their lesions get missed. I've operated on patients with partial anomalous veins that was fixed as an ASD, and the vein was still over in the right atrium and so forth. So, the patient ended up needing an extra operation. So a couple of things that just, a couple of patients I've seen that they were managed because probably, the cardiologist or the surgeons didn't know any better. Another thing that's particularly different or challenging in ACHD is, the maturity of the program that's actually dealing with these patients, and that really changes the composition of the adult population that presents with the disease. Just to give an example, I'm going to talk about just to see the differences between what you see in the Western world and what we have over here. I don't know how well you guys can see. I'm just going to have everyone kind of lean forward. This is from the STS database that has over 1,000 participating surgeons and aesthetists and so forth from most of the major cardiac centers in North America. And as you can see over here, this is a if you look at all the diagnoses, this is a very heterogeneous population. The highest number of cases that were operated on between 2015 and 2018 was for pulmonary insufficiency, most likely from conduit changes. Somewhere down here, and I want you guys to really look at this, is that things such as tetralogy is like down here, with the 1.8% incidence, and VSD or DCRV is like way down here, which is less than 1%. Moving on from the same database, if you look at the primary procedures, the most common procedure performed is a pulmonary valve replacement. And this is most likely from patients who've had tetralogy repairs or some other pulmonary stenosis condition that was repaired in infancy or childhood and now needed a valve replacement. And then the second most often ends up being a pacemaker, and then tricuspid valvuloplasty, which is most likely from Epstein's. Again, if you really look down here, ASD repairs are like somewhere over here, and I'm going to point these out in particular because our data is going to look very different from what you see over here. And tetralogy barely makes a cut on this one, and so forth. So these are very rare conditions that you see in the database over there. Moving on, so in comparison, I'm going to present this on this slide. You can see this is data from Eastern Africa Center over there that has had over 20 years of experience, and they're reporting their 233 procedures that they performed over 20 years. And if you look at the case composition, this is directly opposite to what we just saw from the STS database, where the primary lesions are as high as 41% are the septal defects, which include ASDs, VSDs, partial canals, followed by pulmonary venous anomalies such as partial veins. And then the right heart lesions, Epstein's and tetralogy start figuring up over here also. They have a relatively high rate of patients who had conduit failure and then needed reoperative surgery for that. And then going on to that, this is kind of the procedures that they've performed. So when they for their data, they kind of split it up into primary procedures and reoperative procedures. Primary procedures, you can see again that they're most common ones, and by a far majority are their ASGs and VSGs. So again, the population mix is very different from what you see in from the STS data. As high as 40% were ASGs and VSGs that were fixed in adulthood, which is pretty interesting, when you talk about pulmonary hypertension and all of those things, but I'm not really going to go there, but just to point something out how different this is. And they've done a fair number of RV to PA conduit surgeries, which again, I think is reflective of how long the program's been around and their maturity. So they're probably operating on patients that they, had done their initial surgery about 15 to 20 years earlier. Similarly, if moving forward, this is a paper that was published from India. This is also a single center experience from Chennai that's describing their experience with adult CHT. And this is a little bit older. This is from 2004 to about 2010. So a little bit older data, but very similar composition. Again, 153 patients. Most common lesions are septal lesions, followed by tetralogy, followed by pulmonary stenosis and RVOT obstruction lesions. They looked at their outcome time and what they had. So one thing I'd like to point out is that, when we talk about tetralogies and VSDs themselves, we don't necessarily place them in the complex group. But when you talk about these lesions in an adult, it becomes a completely different ball game because of, associated issues such as pulmonary arterial hypertension and so forth. So they've put all of them in their group B, which is complex CHT. And moving on in their outcomes, they've actually shown that which is also almost intuitive and understandable, that their bypass times were longer, cross-clamp times were longer ICU stays, longer hospital stays, longer need for ventilation during the complex group. So all of these things are pretty important. And if you look at this group of diagnoses, I mean, most of those are lesions that are not the ones that you would normally miss in infancy and childhood, but just because these group of patients are in the LMIC sector, they just, they were probably just not diagnosed earlier. I'm going to go ahead and talk about our experience at AKU. So this is not data that's been published, but this is from our IQ-IC collaborative that we're a part of since 2013. So I just pulled up some of the data from there. So this is not very well, what should I say? I haven't really been able to collect a whole lot of details, but it should be able to give you a good idea of what we've done over here at AKU. So since 2013, we've done about 146 patients. We've been averaging anywhere from 18 to 22 patients per year. That's kind of been our average. The case mix has been pretty similar. By far, the most frequent procedure has been ASG closure. So just keep in mind the numbers are a little bit higher over here because some patients have had a combination of procedures. So we've done a bunch of VSGs, but at least 8 or 9 of those have been done with an aortic valve replacement performed at the same time. Same for the pulmonary valve replacement group. So as you can see, again, a very heterogeneous group, but the primary lesions are usually unrepaired lesions and mostly septal lesions that we've done. The case mix has mostly been RACs 1, 2, and 3, which I think is probably, also a little bit intuitive because these are patients, if there were RACs 4 or 5, which would be hypoplastic left heart and interrupted arches and so forth, those patients probably self-select themselves out of this group, so these are essentially survivors. And this is something that, I remember one of my mentors telling me that when you go practice in an LMIC in Pakistan, the patients that you're going to see are going to be the survivors. These are the ones who have survived in spite of not getting the medical treatment or the surgeries that they needed at an earlier age. So our composition has mostly been RACs 1, 2, and 3. The age has been very variable, anywhere from 17 years to 51. One thing I would like to just mention is that this group does not include bicuspid aortic valves, which developed stenosis later on, so that fell into the adult group. Or the coed groups. I don't have that data over here. This also does not include any rheumatic heart disease, of course. So as you can see, pretty fairly variable group. About 26% of them were cyanotic heart patients. 20 of these patients had previous heart surgeries, which is about 13.7% of the whole cohort. Mostly these were, some of these were previous BT shunts. If I remember correctly, about 6 or 7 of those. And a lot of these were residual lesions such as VSDs, or like I mentioned, previously closed ASDs that now had mitral clefts that hadn't been repaired at the initial operation and so forth. The post-operative outcome, so the length of stay is a little bit, the mean stay was about 7.4 days, which is a little bit higher than our usual when you look at our whole the whole data set from that time. Again, this is unpublished data, so this is just what I pulled up. The ICU stays were about a little bit longer, even though the time on mechanical ventilation is not that long. So this is kind of representative of what I was talking about earlier in terms of what their, they just seem to have a more difficult post-operative course, it seems, even the so-called easier lesions. We saw 3 mortalities in that group. 2 patients came out with open chest. There was 1 surgical site infection. At least 4 patients had reoperations. 3 of these were for bleeding, and 1 was for need for a permanent pacemaker after a AVSD repair. So, again, if you just talked about clinical outcomes, so those aren't so bad. But like I mentioned earlier, what really seems to be affected is what their quality of life seems to be, which seems to be a bigger problem, which we'll talk about. I'll just touch upon it and I'll let the experts talk about it in more detail after my presentation. This is a paper that was published from our center also, which was just looking at the length of stay and why these ACHD patients had, the ones who had a prolonged length of stay, what the causes for those were. And some of the things that they identified were, which is kind of intuitive. You can see that, they basically looked at everything and not quite reaching significance, but for some reason VSD repairs, which may be because of associated pulmonary hypertension and so forth, which may be one of the risk factors for having a prolonged length of stay. Moving on, I know we're running out of time, so I'm just going to quickly go over specific lesions, and I'm going to talk about tetralogy of Fallot in particular. And again, this is because I find this particularly challenging as a surgeon. You think about tetralogy and as a fairly standard lesion. We do a bunch of those, especially over here in Pakistan, but I think adult unrepaired tetralogies present significant challenges to us. And something that I've learned during my time over here has been just their physiology is actually very unique, and most likely due to their long-standing cyanosis. They have a bunch of collaterals. There's significant right ventricular dysfunction that we see in these patients in the post-operative period. Some of the data we actually presented this in at the Japanese Circulation Society meeting earlier in the year in 2020, and we were just looking at their health-related quality of life of these patients. As you can see, I'm just gonna kind of wrap this up quickly and not go into a whole lot of detail. They were, clinical results were pretty good. There weren't a whole lot of post-operative complications in terms of hospital stays and their clinical status. But what we found interesting was that a lot of these patients were actually lost to follow-up, and we had them come back. When they came back for the quality of life assessments, we were using the SF-36 questionnaire and also doing a qualitative study. We also did echoes at the same time. As you can see, their echo findings were fairly decent. They didn't have a whole lot of residual lesions. We did see pulmonary regurgitation, which you would expect. after tetralogy repair, in particular if they had undergone transannular repair. So there was that group. But what was really interesting was what we saw in terms of their quality of life. And, there was a lot of positive reinforcement in terms of when they came up for surgery, but there's significant social stigma that they face because of their disease. And some of the comments will really tell you, there are things like, something that's very important in Pakistan is that, I didn't get enough marriage proposals, or I wasn't able to set up a family and so forth just because of my disease. These are people who are, a lot of them don't go to school, and they're kind of marginalized, even though in terms of their intelligence and IQ, they're fairly normal, but just because of their heart disease, they end up being marginalized in society. And then one of the major reasons that they told us, in the interviews was that they just their parents didn't know better. And obviously the biggest problem is the financial issues, and the families are just unable to afford treatment. So this, when we did a quantitative assessment of their quality of life, like you mentioned, for the most part, they're doing pretty well. But one thing that they really suffered from was their feeling of having enough energy and fatigue, as well as their, the emotional limitations because of this disease. And I don't think, when we did the qualitative interviews, that this was so much as how what they're physically they felt like they were doing okay, but a lot of this was just a psychological impact of having had a chronic disease that they battled with for such a long time. So in conclusion, I just like to end this by saying that, adult congenital heart disease presents a substantial cardiac burden, specifically in our society. And when we talk about managing these, as a surgeon, my goal is to always have a perfect anatomical and a physiological outcome. But what's really more important, well, not more, I wouldn't say more, but just as important, is to have a more rounded and a more holistic approach to the patient. And you have to keep in mind that about the psychological impact, and the impact on their quality of life. And again, this just kind of underlies the importance of developing a robust program that deals with these lesions, especially unrepaired cardiac disease, in early in life. And interventions specifically need to be focused on the management of this disease in infancy and childhood. Thank you.
Thank you, Dr. Malik, for an excellent talk on the, especially sharing with us our local data. That was awesome. And in the end, you actually touched about the health-related quality of life, which will be talked about in detail by Dr. Laila. I have, when I was listening to you, I was just, yes, so our data shows there are a lot of differences from diagnosis up to the outcomes of the ACHD patients when they undergo the surgery. I have a question from Dr. Babar, because Dr. Babar, you have a lot of rich experience in lower middle income countries as well as from the higher income countries. And of course, the best assessment for the surgery is done pre-operatively. So what do you think from your experience? So I have actually two queries. My first question is, what is your experience compared to higher income countries, lower middle income countries? What, if I ask 2 to 3 important parameters in pre-operatively that actually make a patient high risk for the surgery? It is the disease itself, for example, the rare diseases, or it is the approach, difference in the approach between the lower middle income and the higher income countries, or it is like that already known factors related to the patients, like the delayed diagnosis, socioeconomical differences, and etc. And so that's my question. Would be very happy to hear a few words from your experience.
Sure, Farhan. Thank you very much for that question. I think the biggest thing that Mahim just alluded to also is that just to recognize that the disease spectrum is different. So it may carry the same name when it comes to the diagnosis, i.e. tetralogy of Fallot, i.e. VSD, but the disease spectrum is very different when you are dealing with that as an adult unrepaired congenital heart disease. And compound that problem with a lack of data. I think that's the other big thing. And I think that's where the importance of getting data out from our part of the world is important, because 90% of people who have congenital heart disease belong to setups like ours. And so contextual data, which is meaningful to those people, has to come out, because when you are dealing with an unrepaired tetralogy Fallot as an adult, many of the things that you see when you repair them is very different than what you will see in the high income countries, where the disease is being repaired as a neonate or a child. And their adult congenital heart disease is a lot of repaired heart disease. So I think in the preoperative period, that recognition is important, and that changes your way in which you will do their assessment, which means that, how much you'll be using echoes or CTs. Use of MRI is not easy. Very few centers actually have the capability of doing cardiac MRI, congenital MRI, and reading them. So certainly, I would not do an MRI on an ASD who's coming with a adult with an ASD. And if there is specific question that needs to be answered, I just answer them either in the cath lab or use CT scans to do that. But I think preoperative discussion with the surgeon, with the team, and also accounting for the adult acquired heart disease at the same time. So when we close, for example, our ASDs in the cath lab, anybody above 40, we will make sure our adult colleagues are involved, and we are having that active discussion of coronary artery disease and stuff, because the spectrum of coronary artery disease in our part of the world is way early, way younger, and more aggressive. And one has to keep that in mind. So balloon occluding those ASDs, assessing how the LV function is, how the LV diastolic function is, doing a lot of challenges in the cath lab, fluid challenge, exercise challenge, and not just relying on simple resting numbers. And I think that's the other big thing that we do. So those are the things that we kind of keep in mind on. And then financial, yes, one has to think about the finances. Out-of-pocket payment is the main source of treatment in our part of the world. So if you treat them, you just have to make sure that there's some kind of a finite goal that you are trying to achieve. So tetralogy of Fallot, absent pulmonary arteries, discontinuous pulmonary arteries, segmental pulmonary hypertension, those are the things you just don't put your hands in. So that's what my thing and take is.
Thank you, Dr. Babar. So when we are heading towards our discussion, so what the one thing that actually, if we review our literature, so the one thing that is important is that you just highlighted also is the lack of the robust data from lower middle income countries. And we have a lot of good data like presented by Dr. Zaidi and Dr. Leong from the other countries. So my next cross question is to Dr. Zaidi and Dr. Annie, if they can briefly tell us how can a higher income country can build a group collaboration with a lower middle income country to support the research in these areas, because it's a global burden. The congenital heart disease is not the disease of LMIC. It is not the disease of the higher income country only. It's a global burden. So because the robust research requires funds. And the one most important factor that we have seen behind the lack of robust data in lower middle income countries is the lack of the funds. So Dr. Zaidi and Dr. Annie, please put some light over that.
And Marie, if you want to go first, then I'll go next.
Thank you. Well, just a very inspiring discussion and conversation. I would say I think it's our duty to collaborate, and there is really no funding right now in this scope, but I don't think that should limit us with the right collaborations that we have to learn, because we could learn a whole lot from you about how to do this. I was just thinking, when I'm approached with an unrepaired adult with tetralogy, it's a frightening challenge to figure out the right steps with our surgeons. And yes, we do have some of the more advanced imaging technologies, at our institution. But at the end of the day, it really does come down to not just that. It comes down to so much more about physiology and expectations of quality of life. And if someone's lived a certain way for several decades, you know, the discussion about should we change it really has to be encompass all of those things, personal, financial, what the goals are. And so I'm anxious to learn more. And I think that funding aside, we should just continue discussions like this, coming up with in registries and in projects, very simple, small metrics to start to figure out how we could do better. Ali?
Yeah, so I agree, and Marie, and so it's as we can learn just from this session. I won't take too much of your time. And what we're seeing is two spectrums, right? We're seeing the developed spectrum in countries like the United States or in Europe, and then you're seeing the spectrum in a country like Pakistan, or if you take India or other countries that are still developing. They're two different spectrums. They're two different disease populations, same disease, different populations, right? I mean, you're seeing two different spectrums. So your question is really, how should we collaborate? And there is certainly ways to collaborate, as Anne-Marie said, registries, research. These are all, Babar is doing some, and he's done some great work already. We need more. I mean, certainly. The second part that you brought up is an operational question. And so I'm going to wear a little bit of my administrative hat on, is finances and the fiscal arm of this. And that is more challenging, because that becomes, how do you take the same thing that we're doing in developed countries and apply that in a developing country like Pakistan. So I'm actually more interested in listening to the talks that you have at the end of this session, which is one from Farhan, Ahmed, and I think I saw Amy on this as well, because that will give you a perspective from an operational side as to what is needed. So research, registries, collaboration, absolutely. But the operational, administrative, fiscal arm is more challenging. I think that's a bigger discussion.
Thank you, Dr. Zaidi. Thank you, Dr. Annie, for your response. Yes, Dr. Shazia, yes, we agree that advocacy is also one of the factors, and we will talk about. So let's move on to the next speaker, and our next speaker is Dr. Laila Akbar Ladak. So just briefly, I would like to introduce Dr. Laila. Dr. Laila is an assistant professor at the Arkan University School of Nursing and Midwifery, and has a joint appointment at the Department of Pediatrics and Child Health. She's an honorary faculty at the University of Sydney, Australia. Dr. Ladak's PhD thesis and overall research focuses on the long-term outcomes, morbidity, and the health-related quality of life in patients with chronic diseases, especially her focus is on congenital heart diseases. She was a part of the steering committee at the International Consortium of Health Outcome Measured in Developing Standard Sets for Health Outcome Assessment in Congenital Heart Disease that has been released in September 2020, and it was an active participation. She has a various scholarly work and publication to her profile. She's also the lead for the Global Health at the International Society of Adult Congenital Heart Diseases. She will talk about the health-related quality of life with adults with congenital heart disease and perspective from the lower middle income country. Dr. Laila, thank you, and over to you.
Thank you so much. First of all, I would like to thank and congratulate the conference organizers for providing me this opportunity on talking on such an important aspect, which is very near and dear to my heart. And of course, gender matters. So as we are all aware that it is an established fact that with the advancement in diagnostics and clinical and surgical management, the mortality has decreased and survival has increased in the congenital heart disease patient population. And so much so that the adults actually have outnumbered in a number of regions across the world. And around 2/3 of the CHD population, patient population comprises of adults. Though we need to be mindful and ensure that the needs of this patient population varies across different age groups. Despite that these patients undergo through surgical procedures or interventional procedures, the evidence suggests that these patients undergo and they suffer and they do have morbidities even after the surgical procedures or any other intervention that they undergo. So for instance, these patients they have the heart failure, they undergo arrhythmias, and some of them, they actually end up having pacemakers. So that is why it is so important to understand that congenital heart disease is a lifelong disease. And we as healthcare providers, we need to ensure that how we can provide the care to these patients and improve their literacy and improve their understanding that this is not, the surgery may not be the, the destination or the cure or the end of this disease, but this is a lifelong disease. And health-related quality of life is an important aspect of patient health outcomes, and it does not provide the current status of patients' health outcomes, but it also provides screening for the potential health issues which a patient is undergoing. And this has also been highlighted and reinforced by American Heart Association scientific statement. This also provides opportunity for the patients to be the shared decision makers, because when we are talking about patient-reported outcomes, health-related quality of life, patients are part of the decision-making. So therefore, we are empowering the patients, and we are encouraging them, and we are involving them to be part of the decision-making, and they are equal stakeholders in a health decision-making. Despite the fact that we all appreciate and understand that patient-reported outcome measures and health-related quality of life is an important aspect, and this has been discussed in previous presentations as well by different speakers. We as healthcare providers, for some reason, the patient-reported outcomes, what is important to patient, what are their values and beliefs, what are their needs, what are their priorities, this is often ignored. And this is the piece of the puzzle we have been missing in the patient's voice. And we as healthcare providers collectively, we need to ensure that this should be part of the clinical assessment and clinical management. So the systematic review and meta-analysis that was conducted to identify the health-related quality of life in congenital heart disease surgical patients reported that the quality of life was significantly lower when it was compared to their healthy controls. However, there was hardly any data from lower middle income country. And we have discussed in previous presentations, and we appreciate that there are huge differences between high income countries and the low middle income countries in terms of the socio-demographics, in terms of the resources available, in terms of the infrastructure, and particularly when these patient population, they are diagnosed quite at a later age of their lives, as well as even when they are diagnosed, the required intervention that is required, they receive it at quite a later stage. So there is already a lot of physiological compromise in these patients, and therefore the findings from the high income countries, we cannot generalize to low middle income countries. In terms of the CHD distribution, the major disease burden is in the areas or the regions which has lesser resources, like us, like Southeast Asia, and Pakistan is one of those countries. So if we talk about Pakistan, as you can see that we are a population of about 220 million. And in the absence of a data surveillance system, it is estimated that about 50,000 children are born with congenital heart disease every year. However, we have a handful of healthcare providers and the healthcare facilities or the services to provide the required clinical management to these patients. In addition, about 70% of our population, they reside in rural areas, and the literacy rate is also about 60%. This makes it more difficult in terms of not just the literacy, but also the health literacy, and in terms of the issues which these patients, they suffer in terms of the accessibility, availability, and affordability issues. And therefore, the health-related quality of life and the patient-reported outcomes are more important to be addressed in this part of the world. So as part of my doctoral thesis, and this is one of the component of the larger study that I conducted as part of my thesis. So this was a mixed method study that we conducted at a tertiary care hospital in Karachi, Pakistan. The objectives were to determine the health-related quality of life in congenital heart disease adults following surgery and to understand the experiences they are going through after the surgery. So revised Wilson and Cleary model formed the basis for the conception, conduct, and analysis of this study. This model proposes and reinforces that how the characteristics of an individual and the environment, How does it impact the symptoms, functional status, and an overall quality of life of an individual? So the data was collected as it was a mixed method study, so quantitative arm as well as a qualitative arm. So validated questionnaires, speech score, core version, generic quality of life questionnaire, cognitive and cardiac module was used. As AHA has strongly suggested that in addition to the generic or general health related quality of life, if possible, we should also be assessing the disease specific quality of life. And this is what we actually did. And a semi-structured interview guide was developed to understand the experiences of these patients living after the CHD surgery. So there was an equal proportion in terms of gender, and the mean age was around 30 years. About 48% of the study participants, they fell below the poverty line of a low middle income country, and they were married as well. The majority, or rather an equal proportion of them, were living in extended versus nuclear family system. In terms of the CHD severity, majority were from mild to moderate CHD severity, and the age at the diagnosis, as it is very obvious, is about 14 years. And you can see the time lag between the age at diagnosis and the age at first surgery is 10 years. So the mean age at the surgery was around 24, 25 years, and the follow-up period was 4 years. In addition, about 50% of the study participants, they were on cardiac medications. So the overall quality of life of these individuals, or of these adult congenital heart disease patients, as assessed by these validated questionnaires, was overall low. However, the quality of life was much lower in physical functioning, emotional, psychosocial functioning, a total health related quality of life, cognitive functioning, heart problem, which refers to the different symptoms related to cardiac. So for example, dyspnea and not able to perform the activities of daily living, and so on, or arrhythmias, and the treatment anxiety. So these were the major domains under which the quality of health-related quality of life was much lower. In addition, there wasn't any statistically significant difference in terms of the health-related quality of life between mild versus moderate CHD. So while I was preparing this presentation, and I really like this theme that gender matters, and I was reflecting to the participants because yes, the previous slide did give you an idea, an impression that the health-related quality of life was lower in a number of different domains of quality of life. However, the qualitative arm or the qualitative part of the study, it provided us an in-depth understanding of what it actually means. When we say the psychosocial component was low, or maybe emotional functioning was affected the most, what did it actually mean? And we had a very rich data, both from female and male participants. So as you know that in Pakistan and in a lot of other LMICs, we do not have universal health coverage, and it's pay from the pocket. And unfortunately, a lot of females still in this 2021, they are financially dependent or on their male members of their family. So for example, it could be father, it could be husband or brother or son. And therefore they had the reservations, and they were concerned that since the father has passed away, so who would be financially supporting them for the medical checkups, for the medication, all those things. That was highlighted here from our setting. As Dr. Mahim also shared about marriage proposal. So marriage is a core social construct in Pakistan and in many other LMICs. So this female participant who had shared this thing after TOF repair, so she shared that how the marriage proposals were being rejected on and just making silly excuses, because the concern was about the conception and whether the female was medically fit to carry out a lot of other activities or other work like house chores, etc. Because again, there are a lot of socio-cultural aspects that was attached to it. In addition, females or the female participants who were diagnosed after their marriage, during their pregnancy or after the delivery, for them it was a blessing, because their concern was if it would have been diagnosed before the marriage, because they were concerned about the surgical scars and what would be the reaction of the husband and the in-laws. So for them, they were quite happy and glad that this was diagnosed after the marriage, which was very interesting finding and not reported in any other literature. Similarly, since for any surgery or any other medical care, it was pay from the pocket. So the society's perspective and even the close family members was that was it worth investing money on daughter's surgery? Because ultimately she may not be still normal, and the concern was about the marriage. And one of the participants had her own daughter who was 3 or 4 years old diagnosed with the CHD diagnosis, and her concern was about the major surgery and the pain. And she was concerned because she had experienced the experience of her surgery and the pain which she had gone through. So her concern was about how her daughter is going to behave and react to that. Similarly, the society was not considering these patients as normal, as patients were not comfortable taking medications in front of the, other cousins or the other family members. So they sometimes had to skip. Interestingly, a lot of female participants, and because I do not have their codes, they specifically requested, they wanted to share this, but it should not be recorded. So I had to respect that. So they highlighted the need of a female counselor. Because here in Pakistan, talking and discussing about sexual issues and conception related issues, females are majority of the time, they're not comfortable talking to a male a consultant, a cardiac surgeon, or a cardiologist. So it was highly recommended that we need to, and this is something we need to respect. And this was highly identified, like reinforced and suggested by the female participants. So with regard to the male participants, what was their perspective? So in a patriarchal society like Pakistan, some of the responsibilities or the roles have been ascribed by the society. So for example, a male is expected to earn and support the family. And if it's eldest son, then of course the son has to take care of the father's business, getting his sisters married, and be able to work for maybe some outdoor work, or even if sometimes it's indoor work. So a lot of the role ascribed by the society, participants were not able to, because employment was again an issue. So these were some of the issues that were highlighted by the male participants, and that was very specific to gender. Similarly, some of the participants who were very active in sports, this was one of the limitations, because now previously they used to, but now they couldn't because of the surgery and all those. Marriage was again highlighted by both the gender. Males also had some of the issues in terms of when they went through the surgery. So the family members and neighbors, they were a bit conservative that in terms of their marriage and so on. So this is a summary of the different issues that were highlighted by the study participants, both male and female. So as an expansion of my PhD project, we did another study to assess the understanding of the lifelong needs of these adult patients, as well as the healthcare providers in a low middle income country, Pakistan. So the findings were very interesting. Only 11% of the patients, adult congenital heart disease patients, they felt that there's need for lifelong care. And to their understanding, they thought that they should only consult a cardiologist or a consultant or a doctor or a physician or a healthcare provider when it is needed, not as part of a normal routine. Now here comes a very interesting story, because there was discrepancy in terms of what patients stated and responded, and what were the impression and the understanding of healthcare providers were. So since these patients were not regular in the follow-ups, and 87% of these participants, they stated and suggested that it was not recommended to them. However, the healthcare providers felt that they were not regular in the follow-ups. The reasons could be because of the cost, traveling, and accessibility issues, and so many other, the 3 A's and Q that we always talk about. So this was a very interesting finding. As I've shared about the health-related quality of life and patient-reported outcomes, so here comes ICHOM, which is the International Consortium of Health Outcome Measures. They have established, so this organization is an NGO, and it focuses on redefining health. and how health could be redefined from the eyes of the patient. So basically, what is important to patient? And so they have established, they have set the standard set for congenital heart disease. And fortunately, myself, Dr. Babar, and Farhan Ahmed from PCHF, we were representing Pakistan, and we were part of the steering committee team. Before these standard sets were finalized, we also validated. By validation, I didn't mean the scientific validation, but validation in terms of exploring from the patients, adult congenital heart disease patients, and parents of CHD children. To get an understanding of whether these outcome measures that we have set as part of standard, do they feel that this is okay, or there should be some additional things that should be part of it. And again, financial component came up as something that should be part of this. So initially it was, but then with the reinforcement of these patients, so assessing financial component has now become the part of the standard set. And inshallah, we look forward to see Dr. Farhala Baloch, who would inshallah be taking this as her doctoral thesis, to see the implementation and feasibility of ITOM of this, the CHD standard set. And I see Dr. Farhala smiling, so good luck with that. So in terms of the registry, because we did talk about the consortium and registry, so approach IS2, which is the assessment of patterns of patient-reported outcome in adults with congenital heart disease in international study. So the collaborators are KU Leuven University, and AKU is part of the study, where myself and Dr. Babar are the investigators. And this study is being conducted in 40 plus countries and 79 sites, and approximately 18,000 patients and above would be part of this study. So this study is going to bring a lot of robust data from across the world, and there's a huge representation from LMIC as well. So this is a good start. So in terms of where we are going and what we as healthcare providers, particularly for CHD, so how do we see this? So the current, the 2016 Pakistan population pyramid and the projection for 2050, like 3 decades after now, where we are. So you can see a huge difference in terms of the population pyramid. And with the increasing population, there's always increase in the CHD patient population. So we already are under the pressure of the CHD disease burden as an LMIC, as a country, Pakistan, with very limited resources, both in terms of manpower as well as the healthcare services. So where do we see and what should be our approach in terms of some proactive approach that we should take in terms of the required resources and in terms of empowering our patients, improving the health literacy. So this is a huge responsibility that we all need to think and come up with some innovative ideas, collaboration between low-income countries and high-income countries. So the way forward is health-related quality of life should be part of regular clinical screening CHD. We should come up with solutions which address the quality of life and lifelong concerns, which are contextually and socio-culturally relevant and gender-specific. We need to focus on patients' health literacy, developing consortiums and registries, artificial intelligence and machine learning, value-based healthcare, cost-effective strategies as a follow-up for such patients. And I see COVID-19 pandemic as a great opportunity, because we were always discussing about teleclinics and how can we approach patients. A majority of our patients are not compliant and they are not regular in their follow-ups. I think COVID-19, I take this thing as a very positive, learning experience for all of us, that how we have actually tried and implemented, and there were, of course, and there would be some initial challenges, but at least we tried and tested, and I think it has a huge potential that we can look for in terms of mitigating the barriers of traveling and transportation and cost, particularly in the LMIC like Pakistan. So these are the glimpses of some scholarly work from Pakistan towards the contribution of science, literature in the congenital heart disease patients, both for children, adolescents, young adults, and adults. So these are the references. And in the end, I would like to acknowledge my thesis supervisors, Professor Robin Gallagher, Professor Janice Gulick, Dr. Babar Hassan, the patients who were part of my study. And because of them, I was able to complete the study. So thank you so much.
Thank you. An excellent presentation, Dr. Ella. Health-related quality of life is an excellent topic. With the interest of the time, I would actually like to move to the next presenter. We will actually take the question and answer in the end. But I must say that with this last slide, that research I have gone through all these in our even institute and some other like areas. There's a lot of gaps have been identified between the overall health related quality of life between the LMIC and higher income countries, and that it's a big topic, probably beyond the Pulse 2021. Please send the questions to the chat box to Dr. Laila or to us, and we will actually discuss it in the end. We are short of the time. I would humble request to the speakers just. We are actually 30 minutes ahead. Let's move on to Dr. Salman Kirmani, our very own next speaker. Dr. Salman is a medical genetist and a pediatric endocrinologist, and he served as an associate professor in the Department of Pediatrics and Child Health and Medicine. Within cross appointment in pathology and laboratory medicine, Department of Oncology. He did his MBBS from the Dow Medical College, followed by residency and fellowship from the Mara School of Graduate Medical Education. Dr. Kirmani is certified by the American Board of Pediatrics, Medical Genetics, and Pediatrics Endocrinology. He has a rich and diverse experience in education, clinical services, and the research, and he will talk about the role of the incorporating genetics in the clinical care in patients with cardiovascular disease. And of course, when we talk about the CHD, the genetics has a vital role. Dr. Salman, thank you so much, and over to you.
Thank you very much, Farhan. And I'd like to thank the organizers for inviting me to do this talk. I've enjoyed the session thus far. I've learned a lot, and I think hopefully the information I can provide will be very, very contextual to our situation here as well. So thank you to all the luminaries in the field who've shared the podium with me. I'm going to broaden the focus a little bit, not just restricting myself to congenital heart disease, and really talk about incorporating clinical genetics into the care of the cardiovascular patient. So with that, I'll begin. I have no disclosures or no conflicts of interest. The question really is, I really believe that genetics and genomics are ideal clinical applications in the cardiovascular realm, just because, number one, there's a high burden of rare Mendelian disorders, both in the congenital heart disorders realm as well as in adult disease as well. And especially in our context, we have a large population burden as well as consanguinity, which gives us a high proportion of autosomal recessive disorders as well. In addition, as everyone knows, we have a high burden of common multifactorial diseases like diabetes, ischemic heart disease, etc. We know they have a strong genetic component that is yet to be fully explored and manipulated for therapeutic gain. And then, we do know that all of these new therapeutics that will come will be population specific. And so one must get familiar and start learning about the populations that they serve. This is the goal of precision medicine, as you all know, and I think everyone in their own role is trying to get there. It's a bit elusive right now, but I think the journey has begun, and a lot of advances with genomics and data analytics, AI, etc., have really facilitated the leap. Really it requires a paradigm shift now from the standard trial and error basis where you treat a bunch of people and some have adverse events, some have no benefit, and some end up having benefit, to really, where we are probably at currently, which is basically a stratified approach. You take certain clinical parameters, you have certain risk factors that you know about already through previous studies. You try to combine those with some known biomarkers, and you try to do your best. But I think what the goal is, and I think we're trying to get there, is to actually take a multi-omics approach, all the multiple layers. Genomics is just one of them. There's multiple, transcriptomics and other layers that we need to do. And then, layer that up with all the rich phenotypic history, the clinical history, the medical records that can now be electronically analyzed and, in an algorithmic fashion, put that all in there, and then come up with a specific profile for the specific patient, so that when you do your therapies, you're basically trying to benefit each individual subgroup, each individual patient in and of itself. So, really the goal is to deliver the right intervention at the right time to the right patient. With genomics in particular, the cost of sequencing has dropped dramatically. It took 13 years and $3 billion to sequence the first human genome. We can now do it in less than a day for a few $100s. Remarkable progress. We now have genome sequencers the size of a USB stick, where all of the analysis is done on the cloud. So you can actually take this to the field and do this in very, very, very rudimentary settings. And this really leads to the context of that all this genetic knowledge needs to come back to the community. Right now, there are a lot of bottlenecks. A lot of patients who get these studies are at academic medical centers, and we really need to change our healthcare approach about genetics and genomics from a tertiary or quaternary care setup to really the realm of public health genomics. And the NHS has done a fantastic job of embracing genomics into their daily clinical parameters, and so they're actually now covering a lot of genomic testing as well as genomic medicine, which is fabulous to see at a government-sponsored healthcare system. Focusing on genomics, I'm going to primarily talk about the hereditary disorders, although the framework goes way beyond that to complex disorders, cancer genomics, and all the other things that are applications. Pathogen genomics, as we all know today, is taking the forefront in the battle against COVID, but I'm not going to spend time on that. When we talk about hereditary disorders programs, there are a number of specific programs like metabolic diseases, etc., and so forth that begin. And what I'm going to focus on is the cardiovascular genetics program. Why are these important? We can assist with getting an early diagnosis and management of these rare single gene disorders, which really, I think in our setup aren't very rare just because of the reasons I mentioned. We can set up long-term follow-up for these chronic patients who will need multidisciplinary care. And so, a genetic diagnosis is the first step in that direction. We can then give access to these patients to clinical trials with targeted therapies and with gene editing, etc. Really now breaking in to the clinical realm, this will be ideal. And then obviously prevention for the future with regards to reproductive risks. Access to genetic testing in Pakistan is a huge problem. What you see down below are the lists of genetic tests that are available currently within the AKU lab. We end up outsourcing most of our next generation sequencing testing, which is primarily our mode of evaluation for the cardiovascular disease patients, to Invitae Genetics, which is a lab based in San Francisco, or sometimes Prevention Genetics in Wisconsin. Both these labs have been very, very helpful, especially Invitae. And if you look at the pie chart of all the diseases we see, you'll see that about half of our patient volume is actually cancer, hereditary cancer, the bulk being breast and ovarian cancer, but then you see a host of other phenotypes and disorders. With regards to congenital heart disease and cardiovascular disease, we're really sort of in this realm. The pediatric genetics cohort will be the ones with the genetic syndromes that require the diagnosis. Whole exome sequencing will be done on these patients. We will have specific phenotypes like arrhythmia and cardiomyopathy, which I'll talk about. And then some neuromuscular disorder patients will have the associated cardiomyopathies, etc. So how do you go ahead and what have we done to sort of start up our hereditary cardiovascular disorders program? We're only in our infancy, we're just beginning, lots of challenges. I'll share some of those with you, and then we'll end by talking about some of the ideal situations that we can strive for. When we talk about monogenic disorders in cardiovascular medicine, these are sort of the four primary disorders, the channelopathies, cardiomyopathies, hereditary lipid disorders, and the vascular disorders and aortopathies. And then finally, the cardiac complications of the neuromuscular conditions. What is the value addition? I think this is a really important point, because this can be the first and the most unique battle to convince the primary cardiologists or the internists or the pediatricians that we, as a genetics team, as well as the genetic information, can actually help. We now know there's evidence that, all of this information impacts diagnostic, prognostic, and therapeutic decision-making. Risk stratification for, daily medical decisions that cardiologists and surgeons will make, surgical management, device placement, etc., are based on the genetic risk. Possibility of early and targeted treatments, especially with enrollment in clinical trials, is based on these genetic factors, and obviously prevention for the future, as I mentioned before. Everyone knows the realm of channelopathies. This is just as an example, and we know that specific different mutations in the specific channelopathy genes will lead to specific risks and specific management strategies and avoidance of certain high-risk conditions, as well as ICD placement. We know that sudden cardiac death can be the first disease manifestation, and thus it is of imperative need to make a diagnosis as early as possible and do management. And we've actually partnered with our cardiology colleagues quite a bit to make this happen in Pakistan. The good news is that most international agencies will, endorse the fact that genetic testing actually, in an evidence-based fashion, makes a difference and is considered standard of care in most hereditary arrhythmia and cardiomyopathy syndromes. We now know that there is class 1 and class 2 recommendations for diseases like primary pulmonary hypertension in the pediatric setup as well. So a lot of good evidence has gathered, and I think it's just a matter now of making sure that all practicing clinicians know these evidence-based guidelines and can then refer their patients accordingly. And it's our responsibility to make sure they get access to this testing. One of the problems we face for most of you who've sent a patient to a geneticist is this, that it's not a black or white situation when you get results. We love to live on the extremes. We love to get either a benign variant or a pathogenic variant, which we know what to do with, but there's a lot of gray area in the middle, and we end up getting a lot of variants of uncertain significance. Our population is understudied, and that is, the way the VUSs are even more than what we see in Western literature. This is our data over the last 2 years from our hereditary arrhythmia and cardiomyopathy patients. We've, again, we're in our infancy, small numbers here, but we've tested 26 probands, out of whom 12 tested positive for pathogenic variants, which then, we were able to make management decisions based on. You can see that more than half of the patients actually had a variant of uncertain significance, which was tough to deal with. In 3 situations, we were able to actually do parental testing and other family member testing to see and resolve whether this VUS was truly pathogenic or not. But what was really positive here was that in 14 situations, we actually performed cascade screening of family members and were able to establish whether a family member was affected with the same genotype or not, and whether they were at risk for arrhythmia or cardiomyopathy. Here are the spectrum of genes identified in the positive results. The majority of cases were of long QT type 1 due to KCNQ1 pathogenic variants, but you can see a very rare genotype in the Western world was actually seen quite frequently, the MYBPC3 variants, and we had a number of infants who presented with early cardiomyopathy due to MYBPC3 homozygous variants, and then their parents turned out to be heterozygous carriers and either had no current manifestation of disease or were at risk of developing disease later on. And you can see the spectrum of the rest of the genes as well. Here's our data from aortopathy over the last 2 years, and you can see most of these patients met clinical criteria for Marfan syndrome. There's no the FBN1 gene is a large gene, and we wouldn't expect a founder mutation in our population, but most of them had mutations that clearly were pathogenic. A number of negative results, which is good. because as you know, especially in pediatrics, you have patients who have just a pectus deformity, who have certain very soft signs on their cardiac echoes, and you're not quite sure whether they're going to need that close follow-up and that the therapeutic interventions that a patient with a hereditary aortopathy would need. So we were able to actually rule out Marfan syndrome and a lot of related conditions because of that. Less VUSs in this phenotype, which was good. And a lot of cascade screening as well, which was very positive. The challenges, as I mentioned, are the knowledge gap currently within the current clinicians out there, as well as a referral hesitancy. And this really stems from the fact that because there's no local testing, they think that testing will be hugely expensive and unaffordable. So what's the point? And I think we're trying to change that narrative, and we hope that we can do that. And there's conferences like these that will hopefully get the word out. Access is important where, at one academic medical center in one corner of the country, we do get referrals from all over, but we need to increase its capacity all over the country if we're really going to have an impact. Affordability is a big issue. The testing we send currently costs $250, which is about 40,000 rupees. Out of pocket, that is huge for the average Pakistani and mostly unaffordable. And we have to come up with creative ways of making this affordable and trying to find funding, etc., through private donor groups or charity, etc. And finally, as I mentioned, the whole issue of variant interpretation comes back to haunt us every time, because after all these efforts and after all this convincing, what you want to give is a definitive result. And when you cannot do that, all of that anticipation leads to a lot of disappointment. You can see, and I've used this as an example for all of you, that the big orange bars are the VUSs. And in the arrhythmia and cardiomyopathy group, more than half of the time we get VUSs. This is a big problem. And we need to figure out a way to solve it. The only way to solve it really is to study more of our patients and resolve these variants of uncertain significance. And this leads me to a very interesting concept, which all the previous discussions about how the burden of congenital heart disease and all the other diseases are in our part of the world. Here's this problem of what my friend Eric Villain calls the problem of the Mercator projection. This is a world map that most of us are used to looking at typically. And as you can see, when you put this world map sort of on a horizontal plate and you want to put it to scale, the countries in the northern and southern hemisphere, specifically the ones close to the poles, are unusually, unrealistically enlarged. So you can see here, Greenland dwarfing Africa, for example. The real true situation is actually this. And this is where the burden of genetic disease, congenital heart disease, etc., really lies. And this is what we're really trying to get at. Look at now how this, dwarfs North America and most European countries as well. So we need to get contextual data. We need to bring the science to this part of the world so that we can use this data to benefit our people. And so I think, this is the framework that we want to work on. And we're so thankful to colleagues who help us from the Western centers, who help us, build the capacity that we need to solve these problems, because it is in the end our responsibility. And this is really what leads me to say, in the cardiovascular genetics realm, how do we do the ideal situation? The AHA in 2019 brought forward this statement on how to establish specialized clinical cardiovascular genetics programs. And this was, sort of an international statement, and they knew that this was just the beginning. This was their first crack at this, and that this was not going to be easy even in the Western world with lots of resources. But I think it's a good framework and a good model for us to look at and see how we can adapt it to our setting. Basically, a clinical cardiovascular genetics program would include a combined cardiovascular and genetics evaluation in one clinic. It would have cardiovascular physicians, medical geneticists with special interest or experience in cardiovascular disorders. You would have genetic counselors who would take an interest in cardiovascular diseases and put together the other specialist physicians, surgeons, nurses needed to care for these patients. Obviously, need for clinical coordinators and nurse managers is required. There are many different models proposed, and you do need the appropriate allocation of resources to make this successful. There is a cardiovascular component to this and a genetics component to it, and they both kind of go hand in hand. For the patient, it's a sort of a one-stop shop, which makes it ideal for them to bring together all their concerns. But the real question is, what is the value addition of a CVGP? It actually helps right from the outset. It actually helps the geneticist or genetic counselor choose the right test. There are many different choices in genetic testing. If the phenotype or the clinical situation is quite clear, it makes it much easier to do the right test. Otherwise, you can really go down a blind alley. Once the results come in, you can actually have a combined discussion about the variant interpretation, which is key. In isolation, a genetic counselor or a geneticist can never ever interpret things correctly, and the right phenotypic information needs to be incorporated into the interpretation. Because of that, there is shared medical decision making between these teams, and then with obviously the patient and their family. This type of approach will lead to unique training and educational opportunities. If you wanted to establish a fellowship in genetic cardiology, for example, these kind of clinics would be the ideal playground for those trainees. If you wanted to train genetic counselors in cardiovascular genetics, this would be where they would go. And so forth. So huge training opportunities for cardiovascular nurses, cardiovascular genetics nurses, etc. Myriad research opportunities will be established from this, from clinical research to translational research, basically linking all of your clinical work with a biorepository and a registry will automatically get the answers much quicker, much easier. And then through this setup, we will coordinate with referring providers. I think a number of you who work at centers that have well-established adult congenital heart disease programs are using this kind of framework. And I think what the AHA was proposing is to really broaden it to genetics so that a number of these clinics, not just congenital heart disease, can benefit from that kind of approach. And obviously, the psychosocial support will be enhanced because of this kind of approach that you do. What are the recipes for success? I think number one is to have that primary leader or champion. It's hard not to highlight the importance of one person. You do the right hire, you give the right person the right type of autonomy, you let them lead, and they will surprise you. And I think that's what really needs to be done, that one person can bring people together and then really strengthen the team. You need obviously multidisciplinary involvement, and involvement doesn't mean just bringing them in to take care of the patients. It really means involvement in how to run the clinic, what the decision making will be, how to do things, etc., and then really getting feedback constantly. They do highlight that the pediatric and adult cardiologists need to work closely together. This doesn't happen a lot, and I think all of us it's our responsibility to make sure that happens. Genetic counselors are key. They're actually the glue that binds these kind of clinical programs together. You need good data sharing from molecular laboratories, whether they're research labs or clinical labs within your institution or private labs that you use outside. They should be willing to share, things like raw data, share their variant interpretation files, their methodology. All of those things are key in making sure that you're actually progressing and advancing the science. You need the appropriate support systems for patients and families so that they get the answers that they need. They are interested in the research that you do, but they want, in the end, some output for themselves, some benefit for themselves, and it behooves us to make sure we do that for them. And tracking outcomes. It's only if you have a program like this that you'll have the data to track what you're doing. I think a lot of us, unfortunately, especially in our part of the world, we keep talking about numbers and we stop over there. And I think we've got to really, stop having that approach and really go to outcomes. How are we approaching outcomes? And I think a number of talks that we heard today from Nadeem earlier and Laila, we're talking about how we're actually tracking outcomes, and it's phenomenal. And then, once you track your outcomes and once you have your own data, pool that data with other centers doing the same thing. And that's how you create the consortia that really benefit in the end the patients and their families. So here's some, I won't, belabor these, but in the paper, they actually give a proposed workflow for how an initial patient without a known pathogenic variant in the family should be approached and what needs to be done. A lot of work actually needs to be done before the patient even hits your door. And that is key to making sure that you efficiently deal with all the patient information. And then here's a proposed workflow in a situation where you actually, the patient comes from a family with a known pathogenic variant, and then they're presenting to see whether they could have the disease or not. What are the steps in establishing a CVGP? The first step is to actually determine institutional need. And along the same time, you actually have to determine the institutional will. Will the environment support a CVGP? Are all the key ingredients there? Should you do the necessary groundwork to make sure that your clinical cardiology program has all the components before you bring in the genetics piece? Do you want to make sure that you have accessible and affordable genetic testing before you try to put together a CVGP? All of those are important. Then come the nuts and bolts, and I think the devil here lies in the details. How are you going to make this feasible? How are you going to make this work financially? And then, after all of that, you get the commitment and from the clinical leadership. These programs are, maybe not going to be financially feasible in the first 1 or 2 years, but in 5 years, the payback will be huge. And I'm preaching to the choir here. I think with people who do adult congenital heart disease, you guys have probably spent hours and hours trying to convince your leadership, but once you do, it's gold. And then, right at the outset, create or connect with the research infrastructure so that right from the beginning, from day one, you have a well-established registry, you have a biobank, so there are no wasted opportunities. And then you can go ahead and establish the CVGP. And it's interesting, that, once you have something like this, simple things like variants being, classified as, where there's disagreement in variants can actually be resolved quite quickly with just consortia. So, with appropriate data sharing, you can actually resolve a number of variants within your consortia. Even if it's unpublished data, you can actually get it and then publish it all together. And this commitment to variant interpretation is sort of a lifelong commitment, because this will continue to be a problem as you expand genetic testing to multi-ethnic populations. And then finally, all we've talked about so far is monogenic disorders, but, it will ultimately move towards common multifactorial disorders. And I truly believe that monogenic disorders and the study of monogenic disorders will inform, the common diseases like coronary artery disease and diabetes, etc. And I think, right now we're living in this realm where we're living in the rare with, pathogenic variants or mutations with high effect size. But as more and more patients are studied, we'll get the uncommon variants and then the common variants that will have individually low effect size, but collectively actually lead to huge burdens of disease. And that's where the therapeutic opportunities really are. And then, this whole concept that most of you have probably heard about, polygenic disease risk scores are now coming into the clinical realm for most cardiovascular disease. And I think it's important to make sure that we tread carefully in this era and get the data which is specific to our population, because currently all of these polygenic risk scores are applicable to Western populations. They will not be applicable to our population. So I'll end by using the principles of IQRA, which we at AKU use quite proudly, which is when you're embarking on any endeavor, ask yourself, what is the impact that you are wanting to have? Are you going to be able to deliver and maintain the appropriate quality that is required? Is your work of relevance to the population that you serve? And are you going to put in mechanisms to ensure that you will have access, the population will have access to what you are putting together. So with that, I will end, and I'd like to acknowledge our pediatric cardiologists and congenital heart surgeons for keeping the program going and busy. Dr. Yawar and Dr. Azam Shafqat are two adult cardiologists who really kept our adult program going and really keep us busy. And Ms. Fiza Akbar, our genetic counselor and genomic specialist, who's the heart and soul of this program, and it really added this extra, this is the scientific basis of what we do. She puts the data together, and she's really helped bring this forward. So thank you very much, everyone, and I'll end here and happy to take questions on the chat or later on. Thank you.
Thank you, Dr. Salman, for a comprehensive talk. Yes, there are certain couple of questions in the talk. I would be thankful to you if you can go through the talk and just respond to Dr. Shazia and other queries. Thank you so much. We will quickly move to our next speaker because we are short of the time, and it's let's warmly welcome Ms. Amy Verstappen. Amy Verstappen has been a patient advocate and health educator since 1996, when her own challenges living with the congenital heart diseases led her to the Adult Congenital Heart Association, where she served as a president from 2001 to 2013. She has served as an advisor to the National Heart, Lung and Blood Institute, the Center for Disease Control, and the International Society of Adult Congenital and Heart Diseases. And right now she's the president of the Global Alliance for the Rheumatic and Adult Heart Diseases, Global ARCH. A warm welcome to you, Amy, and thank you so much for joining us. Over to you.
Thank you very much, and I'm very honored to be here today to talk about the power of advocacy for adult and rheumatic congenital heart disease patients. So when we talk about advocacy, I think it's important to think about the different levels that we're talking about. So at its most basic level, advocacy is an activity aimed for positive change. And for all of us, a fundamental part of advocacy is self-advocacy, learning how to take care of our own lives, and of course, for those of us living with chronic conditions, our own health. Broader than that in health advocacy would be any activity to improve the availability, safety, and quality of care. So that includes awareness activities, education, which many of you do. And the most narrow definition, which I am going to talk about a fair bit, is policy-directed advocacy. So that would be working with government and other major policy makers to leverage change on behalf of the congenital heart community. Just hold on, there we go. I loved the comment about the Mercator projection because when we look at the global landscape right now, we can see very clearly why there is an urgent need for advocacy in the congenital heart world. Frankly, this idea, when we talk about adults with congenital heart disease, the first thing we need to acknowledge is this is really a possibility for only about 10% of the world's children, because 90% of the world's children live in low and middle income countries. In high income countries, there was universal access to prompt diagnosis and surgery by the middle of the last century, so 1970s, which meant that by 1990, we had 90% survival to age 18. Whereas in low and middle income countries, now, there is largely delayed no diagnosis and minimal access to surgery. So there aren't adults with congenital heart disease, or there are very small numbers, as we have discussed. There is a lot of humanitarian work in this area. It started in the middle of the last century. Again, lots of surgical missions, and now a lot of focus on sustainability, defined as in-country training, working on in-country resources. But when you look at the global level, this has really had minimal large-scale impact. So this is one of the major reasons why the organization I run was founded, to sort of think about how can we change this. A new global burden of disease study was put out last year looking at incidence and prevalence and the burden of disease in congenital heart disease. And there were some interesting findings. The first, very related to our last speaker, which is they found congenital heart disease was present in actually 1.8% live births. So we know that congenital heart disease is the most common birth defect. We have historically said 1 in 100, but they found significantly higher prevalence. And the authors speculate that that is related to the fact that they were getting incidence data from low and middle income settings where there are different kind of genetic risk factors and environmental factors for having a birth defect. Congenital heart disease is the #6 cause of infant mortality globally, and it's the #2 cause in high-income countries. And interestingly, the percent of mortality under 5 and infant mortality caused by congenital heart disease is rising steadily. And that's not because there's more congenital heart disease, it's because as countries work on addressing the other causes of infant mortality and the other causes of childhood mortality, those children with congenital heart disease continue to be there and will be an increasingly large population of the people who need to be taken care of, both as children and as we think about long-term global health, improving overall population health. This is looking at Pakistan in terms of this pattern, and you can see it very clearly. So this is showing the rank, what caused under 5 mortality in Pakistan in 2000 versus 2019. So in 2000, congenital heart disease was ranked number 14 as causes of under.
Amy, sorry to interrupt you. Your slides are not moving. We cannot. We are on the first slide.
Oh,
Still.
my dear. Uh-oh. Can you see
sorry
this
to interrupt you.
No, that's okay.
Still not. It's your first slide. The advocacy, self-advocacy, and.
Okay, let's see. Are you seeing the screen sharing? Okay, my screen sharing is paused.
Yes, we can see your first slide and the introductory slide also. Now we can see your yes, you can go like this if it's comfortable. We can see the slide now. Yes.
You can see it. My apologies. Okay, that's
It's okay.
I'm sorry, and
That's
I
okay.
wish I had knew that sooner, but we will go quickly. So this is the map that I showed in terms of the Mercator problem. Here's the data about burden of disease, and this is the emerging problem. My apologies. Now that you can see it, and my apologies, here is the list of causes of infant under 5 mortality in Pakistan. And you can see that congenital heart disease was the number 14 cause of under 5 mortality in 2000, and in 2019, that had risen to the number 9 most common cause. And the challenge, of course, in addressing congenital heart disease is that unlike all those other causes of childhood mortality, like malaria and diarrheal disease, solving this problem, I don't need to tell anybody on this call, is extremely complex. This is not an issue of one vaccine or primary level care. This is a chart that the people at Children's Heart Link created to show all the variety of healthcare resources that it needed just to diagnose and get a child through their first level surgery, which of course is the basis of adult congenital heart care. So this is very different than those other health problems we face. And then when we look to adult congenital heart care, we can see that it's even more complicated than that. So as everybody on this call knows, an adult congenital heart program, in addition to all the services that are required in the pediatric realm to get surgery, has lots of additional training, most fundamentally 2 trained adult congenital heart care providers and 2 congenital heart surgeons. So this chart on the left was a study that was done in 2013, which had a very generous definition of what an adult congenital heart program was. It defined it as any center that had published any study on adult congenital heart disease. And basically, in a nutshell, if you look at this map, all the red and pink are places where there is less than 1 adult congenital heart program, broadly defined, to 20 million people. Most of them, there are over 40 million people. And as many of you know, most places this just doesn't really exist at all. And as has been discussed repeatedly, changing this landscape is going to take government engagement. So the way you get health policy change is to get on government's agenda. And because I think a major reason why we haven't seen bigger improvement in this area is that all the activities have been very focused on the humanitarian level, on what everybody on this call does, on providing the direct care on the clinical level. But truthfully, there is no country in the world that can do this without major government buy-in. You have to be on the government agenda. There has to be policies and laws that support that. You have to be embedded in the government data system. You need quality standards. And most importantly, you need funding. You need funding for the centers and funding so that the patients and families can afford the care. So how do we do that? Well, the Global Alliance for Rheumatic Congenital Heart Disease was started in part because we believe that an essential piece of changing that, an essential piece of advocacy, is engaging with the patient and family organizations around the world. Doing this kind of advocacy, whether on the awareness building level with patients and families or with government, is what these groups do. And this is just a picture of 5 of our member organizations, each of them meeting directly with the health ministry or officials in their country. So this is the US, Lebanon, Bulgaria, Namibia, and Pakistan. So these groups have a unique ability and power to actually leverage change by being at the front line of advocacy with governments. The Global Arch, the Global Alliance for Rheumatic and Congenital Hearts, was founded in 2017, and our mission is to create a common voice for congenital and rheumatic heart disease. We focus on collaboration and connection, and we really want to promote shared action and advocacy. And when I talk about advocacy, we support our groups in all their levels of advocacy, but our specific target is to promote government advocacy as well, to move more groups into this level of action. And at our founding, we stated very clearly that every person with congenital heart disease has the right to lifelong health and well-being. This is a right that the World Health Organization states for every person. There isn't an exception for congenital heart patients, and that right is lifelong. Currently, Global Arch has 30 group members in 24 countries, and a half of our groups are in low and middle income countries. Our mission is to improve worldwide lifelong outcomes in childhood onset heart disease through empowering patient and family organizations. So we work primarily at the organizational level, and that concept of lifelong is embedded deeply in our mission. I want to pause here to say that I think, as was mentioned at the beginning, I ran the Adult Congenital Heart Association in the US for 13 years. I've been working on advocating for adult congenital heart care needs for over 20 years at this point. And I will state bluntly that essentially I think high-income countries have failed or profoundly failed in some really important ways. We're still playing catch up, and there was a huge error made, which is an avoidable error. So first of all, in the middle of the last century, when this care started, we didn't appreciate that congenital heart disease was a chronic disease, and so planning was not done. But the second error was that when advocacy and awareness activities began, it was siloed. So there's congenital heart activities over here, or pediatric, and then adult activities over here. And the pediatric and adult congenital cardiology communities were relatively siloed. I think that this is a huge opportunity for those of you who are just sort of building your congenital cardiac systems. You can avoid the error that we made. We should note that despite what you might think, the large majority of adult congenital heart patients in high-income countries are not getting appropriate care. So a recent 2019 survey found that 78% of European countries where cost is not a barrier are not getting appropriate adult congenital heart care. And shockingly, they looked at 96 adult congenital heart programs. Only 4% of them met the quality guidelines established in their country's guidelines. We often think about the loss to care issue as a teen issue. This has been repeatedly over and over been shown not to be true. Loss to care is a pediatric issue. So there just was a study that came out that showed that in the US, in this one study, 47% of the families had left regular cardiac follow-up by age 5. Okay, this is not a teen issue, and we're not doing well globally and in high-income countries. That means we have high levels of avoidable morbidity and mortality. We have really good data now to show that if adults with congenital heart disease are taken care of either out of care or taken care of in regular adult cardiology settings, they have much higher rates of death and disability. So this is really a crisis, and it was preventable, arguably. And again, huge disparity issues. So in the US and in other high-income countries, when you start looking at who gets the care, there's another level of challenge, which is that for racial minorities, for people economically disadvantaged, this picture becomes much bleaker. So I think that as low and middle income countries develop your approaches, we in high income countries have a huge amount to learn from you. Because if we're going to solve this problem, we need a solution that does not rely on the patients having a lot of money. It needs to not rely on patients having high levels of health literacy, and it needs to be cost effective, and it needs to reach everybody. So this is embedded in the Global Arch approach. We start from the beginning. This is not about pediatrics and adults. It's about all of us together planning for a future from day one. One of the tools we have for advocacy at Global Arch is we've created the first Declaration of Rights of individuals affected by childhood onset heart disease. And I encourage all of you to look at this. It's at our website, and it's a health policy document, but in summary, it outlines very specific rights. A lot of these have been focused on in previous talks that each of us have. So we have a right to care that is affordable, accessible, safe, high quality, patient-centered, and lifelong. But just as importantly, we have a right to well-being, including protection from stigma, social inclusion, education and employment, medical privacy, and social benefits. And to achieve these rights, the governments have certain actions that they must do. First of all, they have to fund detection, surgery, and long-term care. That's very straightforward. But they also need to collect and report health outcomes and outcomes in social well-being. So this needs to be embedded in the system. We need to create and enforce national quality standards and promote patient-centered care. You need to include congenital heart disease in existing disability and disease services and benefits. Many countries have lots of programs for this, but congenital heart disease has not been included. Raise awareness and combat stigma, and promote and support congenital and rheumatic heart disease patient organizations. That's what our Rights Declaration says in a nutshell. So what are we doing with this declaration? Well, the first thing, of course, is we're looking for endorsements. I hope that each of you, if you're involved with an organization, will go to our website and endorse the declaration. That's a way to show your support. We are running social media campaigns, and here's some examples of the kinds of campaigns we're running around this initiative. But we're also using this as a tool. The declaration, as I said, it outlines very specific goals and objectives that groups and individuals, any organization can take to sort of do an assessment of which of these things do this patient population have, and what are the most important needs to focus on, and use it with government and policymakers. I will note that Global Arch has been at 2 previous UN General Assemblies to represent the CHD world. We had 4 in-person meetings planned in 2020 in Africa, India, the US, and Africa, India, and Europe. And of course, COVID has had a big impact on that. So we're working on how to move that forward in this COVID era. So what can you do? As I said, I hope that each of you will endorse the declaration at globalarch.org. Global Arch is developing regional networks, and if you go to our website and you join, you will get more information about how to do that. I really encourage you to engage and collaborate with your patient family organizations, and we have a wonderful one that's going to be talking next, because the key to success in this area is patient-provider partnership. We have to have a new approach to congenital heart disease that takes a lifelong approach from the very beginning, and have this be part of the conversation. What is the long-term plan for these children? What are the long-term plan for these adults, and how can we work together to get there? Thank you.
Excellent. Thank you so much, Amy, for a fantastic talk. So it was actually the summary of all the questions that we were actually looking for, and I hope that our next talk will actually give us the very good flavor to the whole session. Let's move on to our next speaker. And our next speaker is Farhan Ahmed. Farhan is a social innovator and a philanthropist who has devoted to his life to develop to help children born with the congenital heart diseases. Being the founder and the CEO of the Pakistan Children's Heart Foundation, an NGO working towards building the Pakistan's first children's heart hospital and the research institute. Thank you, Farhan, for accepting our invitation, for joining us. And Farhan will talk about the vision of Pakistan Children's Heart Foundation.
Thank you very much. It is absolutely an honor for me to be one of the person who's speaking. And let me first congratulate you. Such a wonderful event. This is, I think, perhaps first conference where majority of my mentors are here. So I can see Dr. Babar, I can see Dr. Ali Zaidi, I can see Amy, I can see Dr. Mahim, and of course I can see Dr. Laila, and now Farhan yourself. So absolute honor to be part of this. I would like to be as quick as possible. You guys know already that we have a huge disease burden. Almost like 50,000 kids are born every year in Pakistan alone. We have only very few, like less than 30 pediatric cardiologists and less than 8 pediatric surgeons. And we have only 6 to 8 departments where currently the whole country is operating on. Unfortunately, one of the government hospitals, we have about 14,000 children who are still waiting for their congenital heart treatment to be done. So there's a huge lack of trained staff. About Pakistan Children's Heart Foundation, I would like to take you back to the 2012. Unfortunately, we had an incident. My little daughter was born with this congenital heart disease. She lived with us for about 3 years. Unfortunately, she couldn't make it. However, during those times when she was in the hospital, we realized that people who have money and people who do not have money have a serious challenge regarding congenital heart treatment availability in our country.
So we cannot see, sorry to interrupt you. We cannot see your slides moving. I think you are out of the slideshow. Yes, we can see your first slide only. Sorry to interrupt you.
Let me just fix it. Yeah, no problem. Just allow me a second. And
we can see your presentation, but it's like it's not in the slide mode. So
what happened to me?
Better now?
To you?
Is it okay?
We can. It's still not in the slideshow mode. Can you just move on to the next slide and see whether they are moving or not?
Okay. This was my first slide, and now I am on the next slide.
No, we can. Your screen is still on the first slide.
Okay, let me just do it again. Sorry.
Yes, we can see now. Thank you so much.
How about this? Is it now visible?
Okay. Yes, it is visible now.
Okay, so 2012, we formed this institution, Pakistan Children's Heart Foundation, and our main focus is actually 4 areas. The first one is we provide financial assistance to children born with congenital heart disease. Of course, we are focused on awareness and advocacy about such a huge disease we are currently going through. The third thing that we are focused on is capacity building, which is bringing medical missions from outside Pakistan. And of course, our ultimate goal is to build a 75-bedded congenital heart disease Children's Heart Hospital and Research Institute. While we speak, I'll just quickly update you our achievement. There's still a lot to be done. However, till date, we have been able to financially support about 2,254 plus surgeries. This presentation is a little outdated. I'm sorry about that. We've been able to spend about 830 million. And luckily, our mortality as of today in supporting the congenital heart treatment has been less than 4.62%. All right, what is our vision? What do we really want to achieve? So what we really want to achieve that not a single congenital heart disease patient should remain untreated in our country. That's the vision that we all, as board member, as parents, as advocates, would like this to achieve. This should be regardless of the race, religion, gender, financial background, because we believe every child who's born with congenital heart disease has a equal right to live. PCHF mission is to establish a state-of-the-art medical facility, irrespective of socioeconomic status of any child born with congenital heart disease. And our focus is to train the healthcare professional, educate public at large, and provide the highest quality of care, irrespective of the financial status of a patient. About myself, I am a technology, I shouldn't be saying guru, but somebody who owns a technology company. I went through a personal experience. My daughter Aisha, she's no more with us, but her memories have kept us every day engaged with this project more than a previous day. We're also lucky to have Ms. Baul Haq, who has been one of the most successful captain in the history of Pakistan. And he's also one of the board members. And now he's the face of helping us build a dedicated Children's Heart Hospital and Research Institute. We are focused on 4 areas. Project CHIDI is Children's Heart Hospital Research Institute. In the phase 1, we are planning to have about 75-bedded facility functional in the next 2 years. Project Daniel, which is bringing medical mission from abroad and ensuring that our local teams are also equipped the way international teams are working. So we have been very lucky in getting in touch with a lot of cardiologists and cardiac surgeons outside Pakistan. We have been able to bring 4 medical missions that I'm going to share in a while. The third thing which we are focused on is Project Mohsin, which is financially supporting the heart treatment of children born with congenital heart disease. And of course, awareness is one of the major things we all are currently focused on. Project Daniel, I'll briefly update you that we did about 4 workshops, and due to pandemic last year, we were not being able to successfully execute that. Our first workshop was surgical, where we brought teams from US, Canada, and also Qatar and Saudi Arabia. There were people who came to Lahore and Faisalabad, and we did some cases here together with the doctors. And luckily, we were able to support Faisalabad Institute of Cardiology to start their pediatric intensive program. Again, the objective of these medical missions is to learn from the best practices outside Pakistan and then collaborate with the doctors and the wonderful people who are working here in congenital heart disease community in Pakistan. We also did few cardiology workshops in Multan, Lahore, and also Peshawar. One of the things that we focused on was collecting post-ICU staff from all across North, and then we trained them on the best practices which are there in Sidra and other strategic institutes. Project Mohsin, we have been very lucky. By the way, this is where I would like to highlight the other question that came from Ali and the other participants. We are one of those countries where health and education has always been priority for public and private sector. Luckily, this current government, they have been able to introduce universal health coverage for all KPK, one of the province, irrespective of who they are. And we have been very lucky that we have been able to support, we have just recently been able to support this in staff card. And they're not paying 100%, but at least they've started to pay almost like 70-80% of the treatment. So the deficit, about 20-30%, we are still doing as a charity. Right now, we own one of the pediatric cardiac surgical setup in University of Lahore, which is currently we are doing about 170 cases. We hope to expand that to 400 cases. And out of that, if majority patient come from KPK, we hope that this will definitely change how waiting lists are there. Awareness and advocacy is one of the major things we are focused on. Whenever we get a chance, we either go bicycle rides, we go to the TV, we go to other institutions, we talk about a lot on the challenge, because we believe that as parent, as somebody who suffered from congenital heart challenge, we should be able to at least speak and let the world know that there is a problem. If we believe there is a problem, only then we can fix it later on. Quickly about the hospital that we are currently in the process of building. On the 12th of September 2020, we did the groundbreaking of Pakistan's first dedicated Children's Heart Hospital Research Institute. We have currently done the excavation of first basement. We are planning to do the excavation of second basement in the next few weeks. We plan to have about 4 operation theaters. We plan to have a dedicated floor for teams coming from abroad. It's a huge project, but nothing is huge in terms of charity work, because what we believe that till date we have been very, very lucky. People do realize that this issue needs to be addressed, and they've been very, very helpful in supporting. Luckily, we were able to support about 830 million rupees as of today. So what we are looking for is 2 times to what we have currently raised. So if we are able to raise the other amount, hopefully in the next 2 years, we should be able to have a dedicated Children's Heart Hospital and Research Institute facility in the phase 1. We are also lucky to have these institutions supporting us. University of Lahore, they have helped us. They have donated 99 years lease land to us. We are also lucky to have IQIC, who has been, you guys know better than me, since I'm not a medical doctor, but we are the center here in Punjab who have from the day one supported the best practices which IQIC has provided. Global Arc, Amy, one of my mentor, and thank you very much, Amy, for being there always. I am also one of the small board members, but we are trying our level best that how advocacy can help us do a lot together. We are also lucky to have Pro Health as our strategic partner, who has helped us today in terms of designing, and by the way, they have not charged a single penny as of today. This is the location where hospital facility is based. The detailed working is done, what's going to be in the basement, ground, first, second, third floor. So we're going to have a research center also in the first phase. Why we have chosen this facility? Because it is very close to another tertiary care hospital. The facility is very much accessible 24/7 from the parents coming from abroad. This facility is also just like 30 minutes away from airport, about 30 minutes from the center of the city, and 20 minutes from. So it's right in the middle of a place where people can easily reach within the city and outside as well. Current funding status for the hospital construction, phase 1, and again in the phase 1 we have divided into another sub phase. We are currently looking for 290 million. Out of that, we have been able to achieve 90 million, and out of that, about 20 million has been already spent on the project. 102 million pledges are there, and these pledges are, by the way, the real pledges. It's not like if somebody will commit and will not deliver. We have a very dedicated, committed PCHF team who focused on making sure that the concerns of donor are being addressed. And by the way, we have a very strategic donor management system which helps the donor know exactly where his money has been spent and which part of the money is spent according to the zakat needs, which are one of the major things in our country. This is the last few weeks ago picture. We have done the first excavation, and in the next few weeks we're going to be doing the second excavation. These are our strategic partners. They've been able to help us donate. All these individuals, they have done 5 million pledges, and we have given them a possibility to have their logo on our sponsorship wall. So we are currently short of about 23 logos, and which we believe, of course, people like you will help us do the awareness. These are our project PCHF directors. We have a mix individual from business, from doctors side. We're also lucky to have Pakistan Children's Heart Foundation North America, a registered charity in the US, and we're lucky to have Dr. Ali Zaidi on board and other strategic board members who really do all this, without any monetary benefit. We do have an advisory members where Dr. Masood, Dr. Asim, Dr. Saif, Dr. Salman Shah, Dr. Saida, and of course, we are very thankful to have Dr. Babar Hassan as our research advisory member. We also have Dr. Faisal Chima and a lot of other members. So somebody is representing from the business side, And what we believe that it should not be an institution specific to a family or a parent. It should be an institution led by the people who have excelled in their field. So we are very, very lucky to have all those individuals. And I'm very proud and honored that majority of these are committed, focused on ensuring how PCHF can really make some difference in the congenital heart community. We have been very, very transparent since inception. All our funding details are there on our website. Also, from the day one, we have been registered with Pakistan Center for Philanthropy. We are SCCP registered. We are tax exempted. We are also audited by Ernst Young. So what do we expect from you? And I really appreciate your such a wonderful support to our cause. The first thing we expect is to spread awareness, help us achieve our goals. Second, we would like you to be our ambassador. It's very easy, just simply go to our website, drop an email, and then our team will contact you. Of course, any donation, be it a single dollar, a single rupee, or any special donation you want to do it for Sadaqah Jariyah, like you spend something on the hospital construction, there are different accounts for each. Another thing you can do is become a volunteer and refer a child. If you know any deserving children, be it in Karachi, Sindh, Balochistan, KPK, Gilgit, just refer to us, and inshallah we'll definitely going to be supporting them. And any research work where I believe Dr. Farhala, Dr. Laila can help us in all this. So that's it. Thank you very much for being such a wonderful audience, and I'm there for any question you may have.
Excellent, fantastic. I'm just speechless, Farhan. Thank you so much. And and congratulations, and wish you a lot of good luck. And yes, we are with you. So let's move on to to the next videos. When we talk about the advocacy and health-related quality of the life, the patients and the congenital heart disease patients and the congenital and the families that take care of these patients at the pediatric or the adult groups, their voice is really, really must to hear, because there's a paradigm shift seen now in the world from volume to the value-based healthcare. And if we talk about the framework of the value-based healthcare, then the patient-reported outcomes and the outcomes, especially the patient-reported outcomes, are a fundamental part of that value-based healthcare framework. So this session was not complete without hearing our CHD patient and CHD parent. I'm honored to have one of my congenital heart disease patient and my congenital heart disease mother. I would first like to, they have actually shared very nice brief video messages for us and for the community like them, for the patients of CHD, for the parents, an inspirational video. I would like to briefly tell about the Mavish. Mavish is a radio broadcaster and teacher, social activist, a motivational speaker, and a blogger in Lahore, Pakistan. As a mother of a son with congenital heart disease, which is rare, which like difficult to treat in an LMIC, a single ventricle, she's a tireless advocate for CHD patients and helping other families find proper cardiac care for their CHD children. And recently, the Mavish was actually selected as an advocate for the global ARCH also. I would like to request Salima or Mariam to just, can you please share the video message of the Mavish? The volume is low. Salima, the volume is still low. We cannot hear. We can't hear. It's still not working. It doesn't work.
This is
Okay, let's move to the Amina's video. Till that you can work on the Mavish. So we have. So let me introduce very beautiful Amina. Amina is physicist from NET University, Karachi. Many of you must be aware of that. She was an active in sports during the entire of her academic life before she was diagnosed with the congenital heart disease at the age of 19, which is atrial septal defect. After which was actually complicated at that level and extensive workup was done, and she was having Alzheimer's. She had to leave the sports behind, but she never leave a fight with the life. She also has a passion for arts, and her sketch of the heart and her story is actually going to be published soon in the Children's Heart Foundation. She has actually very happily shared few words, her voice, inspirational voice for a CHD patients to be the part of this session. May I request Mariam Salima, can you please share the video message of Amina here? No, it's not working. We cannot hear. Mavish, are you with us? Mavish, can you please unmute yourself and please say a few words? I'm sorry, the video, there's some issue in the voice. For the Mavish is with us. Mavish, can you just please share a few words with us? Mavish, you need to mute yourself because we cannot hear you.
Now you can hear me?
Yes, we can hear you, Mavish. Thank you so much.
Mavish, can we see you as well? Can you turn on your video?
Yeah, please. Video, yes.
Okay, I'm here. Thank you so much for this opportunity. And I am a mother of a CHD child. He is, his condition is aortic atresia with few more complications. And he is not purely HLHS. Our journey is like a rough road, which you all have mentioned before, that there are many barriers, many difficulties in countries like Pakistan. From the search of a proper treatment to finance management, for us, nothing was easy. It was very difficult. We researched a lot throughout this period. And during this whole time, I observed the health sector very closely in Pakistan. And there are many issues over here, and what I feel that there should be proper solutions for that. I opened all my social media platforms for the other parents because I never wanted the same situation which we have faced. The other parents should also go from the same situation. So I opened all my platforms for them, stayed in contact with them, and felt that there is a dire need of a CHD awareness and advocacy. Although we used to feel that there will be one surgery or one follow-up is required after surgery and the journey will end. It's not like this. There is a fact that there is no one surgery or two follow-ups. So there is a need of proper national health policy for CHD in Pakistan. And along with that, I feel that as a parent, knowledge is power. And a CHD parent must empower themselves with the knowledge of their child condition, treatment, medication, and other factors. we should learn as much as we can, because only we can know the best for our kids. Random post on social media might be helpful for support or for stress relief, but I believe that we should contact and consult our cardiologists and doctors for proper knowledge, and should rely on the best possible sources. After seeing all these things, I made a platform or a group on Facebook too, where CHD families and parents can connect. I guess the little part which I'm playing right now might be the big one if we all will be connected. And this is not just you all heroes are doing work. We as families and CHD parent are also trying our best to be the part of this thing, and hopefully there will be a bright future. I'm playing my part.
Thank you so much, Mavish. I'm so sorry, but actually, I'm so glad that I hear you directly here. Thank you for being the part of that, and believe me, the patient and the parents' voice is an integral part of the CHD care. So let's move on to our patient. Her video is now she's not with us. She just dropped a message. So let's move on to her 1 minute video. And Amina, we missed you actually in the session, and let's hear what Amina talk about her journey as an CHD patient. Salima, can you please just play on?
My name is Memish and I'm a mother of a CHD child. His condition is aortic atresia along with few more complications. He is not purely HLHS. Our journey is like a rough road from search of proper treatment to finance management. Nothing was easy. We researched a lot during this time period. Throughout our journey, I observed our health sector very closely. There are many issues for which proper solutions are required. I opened all my social media platforms for other CHD parents. Stayed in contact.
Next. सलीमा ये बात कर चुकी है. Next की वीडियो चलानी है. ठीक है, इसके बाद जब ये खत्म हो तो.
Hello everyone. So this is the message from a nerdy, artistic, crazy sports girl, also known to be a physicist. The girl one day knew that she had CHD. Did she give hope? Did she lose up? I don't know. Maybe all of you will get the answer in the end of my message. The crazy sports girl is first sitting in front of you. Yes, this is me. I'm here, Sayyida Amina Amir. We aren't abnormal. We are supernormal. I created this word for me the day I was told I am an ASD patient, radial septal defect. And yes, we are supernormal because we can do all the things like normal people, but they aren't blessed like we are with strength, calmness, patience, kind-heartedness, and a smile on our face. Not only we are blessed, but our parents are also blessed because their gardens bloom with extraordinary and talented flowers like us. Yes, I used to be worried a lot. Then without really knowing, I changed. I now worry about what would happen if I don't live my life at best, and what would I miss and not remembering all the moments, places, and that's because of the people who surround me, who taught me how to wonder. And there are always bright places in the dark time, and if there isn't, you can be that bright place with infinite capacity. And it's fine to be lonely, get lost, to feel weak, depressed, as long as you find your way back. So in the last, I would like to say, God choose to give the most suffering to those who He loves a lot. And so believe in you. You are super normal. You can achieve anything and become anything. Thank you.
Thank you, Amina. Thank you so much. So here, this is the time to conclude, actually. I would actually like to ask brief conclusion remarks by my all honorable panelists, Dr. Ali Zaidi, Dr. Amy, Dr. Ali Zubairi. We have a surgeon and panelist, Dr. Waris Ahmed. I would like to hear a few conclusion remarks about the today's session, your viewpoints, what are the gaps, what are our achievements, and how can we actually collaborate. I think it's like too late here, but it's early morning in the US. So Dr. Zaidi must be very fresh and Dr. Amy. Yeah, so please, over to you.
Yeah, sure. I can start. I'd love to hear what Anne Marie has to say and other panelists. Listen, I'll keep it short. It's first, congratulations to you guys at Aga Khan to put this together. AKU should be very proud of everything that you guys are doing, from what Salman Kirmani showed, from what Babar has done, and Nadeem yourself. I think it's tremendous. And to Amy's point, I'll just put it in two contexts. What you guys are trying to achieve from an advocacy standpoint for congenital heart disease for children and adults is tremendous. It is not easily done. Even here in the United States, I can speak for other countries which are developed, it's a challenge for us. It's not easy for us to do what you are trying to do. So you're doing it with limited resources. More power to you, more kudos to you. Tremendous achievement on that standpoint. One other thing I'll tell you is what Farhan Ahmed showed for the Children's Hospital that he's trying to work on. Again, tremendous initiative. Advocacy and operations to make it work on the ground and not just be up in the air is a huge task. You talk to anybody who's worked in developed centers, these are not easy things to do. To sit with administration, with leadership, talk to them about product development. Many kudos to you. We're happy to collaborate in any way we can. I don't know what the right arms to that are, but tremendous work. So congratulations. I'm going to hand this to the other panelists. I'd love to hear what other people say. So congratulations.
Thank you, Dr. Zaidi. Dr. Annie, few words, please.
Well, I agree. Thank you so much. This has just been a wonderful program, the breadth and the depth of what I've learned and the various topics and collaborations. I'd be optimistic. I think that doing what you're doing is a tremendous start, and that we just need to focus on, again, just looking at metrics as far as reasonable goals and not just including one area such as imaging or hemodynamics, but really looking at the whole patient. So it's just wonderful to hear those last several presentations as well. And in doing that, there are many of us throughout the world that would embrace collaboration, because we learn as we do this as well. And so I'll just put that out there to say thank you all so much, all the way back from Boston. We look forward to the future.
Thank you so much, and thank you for joining us. Dr. Ali Zubairi, are you with us, sir? Dr. Ali? He's our professor of pulmonology and a specialist in ILD and actually group 3 pulmonary hypertension. I think Dr. Shazia Mohsen, our very own pediatric non-invasive cardiologist, expert in congenital heart disease, imaging in congenital heart disease, would like to hear a few concluding words from you also.
Thank you. Thank you, Farhan, and thank you for this excellent session. Thank you, Dr. Ali Zaidi, and thank you, Amy, Mehvish, all the speakers. So we are right on track. I think we are working towards, like Farhan and Mehvish, and we all as a team are working towards the advocacy for this congenital heart disease. And as Dr. Zaidi mentioned, that we are working with our limited resources, but we all need to remember one thing, that quality is very important in all this work. Quality in imaging, quality in cath, quality in patient advocacy, quality in patient care. Because sometimes this is the only, I'll speak for echo, this is the only modality that the patient has before going to surgery. So we have very limited margins for error in our limited resources. So thank you all.
Thank you so much, Dr. Shazia. Dr. Baba has already left, so I think so. Let's conclude it. I would actually conclude this session, and then I will move on to Dr. Saira Bukhari, our chair of organizing committee, to actually say some word of thanks, because this is the last session of the Pulse. And thank you so much for staying with us so late and so early in the morning, and actually spending your Sunday morning with us. I think when we talk about the adult congenital heart diseases, it's there are two-phase transition: a transition of the patient from the pediatric to the adult life, and then a transition of a care also. Transition of I can say it's a professional transition also. No doubt there is a need for a collaborative work between the lower middle income country, high income countries, between a pediatric and an adult cardiologist, because that's the way, and the advocacy, and that's the way we can actually improve the health related quality of life, and all we can actually work on all the three domains, which is the physical, mental, and social of this chronic disease, which actually a person is born with it. So with this, I would like to say my esteemed gratitude to all my esteemed experts, speakers, and panelists: Dr. Zaidi, Dr. Annie, Dr. Babar Hassan, Dr. Shazia, Dr. Waris Ahmed. Are you with us, sir?
Yes. Assalamu alaikum.
Oh, Dr. Waris.
Oh,
yes, walaikum salam. Walaikum salam. Please.
Yeah, I was just writing actually. This is amazing organization. I have to say, everybody. I have to say, everybody just stayed throughout the talks. Very nicely laid, actually, and very nicely delivered. Thank you, everybody from across the globe, to be with us at AKU, and thanks Farhan for organizing such a very nicely organized meeting. Thoroughly enjoyed it. Thank you.
Thank you, Dr. Waris. And actually, we were actually seeing your questions in the chat also. Thank you so much. So thank you all the speakers, Dr. Salman, Dr. Nadeem, and thank you to Amy. Thank you to Dr. Mahim Malik and Dr. Zaidi as a speaker also. Thank you to Dr. Laila. She actually just left. And thank you to Mavish and Amina for being part of our session. I would now like to request Dr. Saira Bukhari to say a vote of thanks for the Pulse 2021. Dr. Saira, please, over to you. Dr. Saira, are you with us? Hello, Dr. Saira, are you with us?
Yes, I am actually. So I was having trouble getting myself unmuted. But Allah, thank you so much. I think this has been a wonderful session. I hope I don't sound tone deaf by giving a vote of thanks. So I'll just start by saying a few words about basically our efforts to recognize that ACHD is a big problem. It is our problem, and we will strongly advocate for the patient and for the whichever physician wants to dedicate their lives towards this passion. So let me start by thanking our esteemed speakers, our panelists and participants. This was all worthwhile because you attended and you were so interested. And there was, I think there were extremely robust discussions. We were privileged to host many giants in the field of cardiology, and your life's work has defined what modern cardiology practice means. So I think it was a bit of a fan moment for us even throughout this session, and so many stars were here. I would like to thank all of our guests for their advocacy for the patient, and especially what the patient considers to be quality of life, for advocating common sense in our management, for advocating gender sensitization and gender equity. I actually have a long list of people to thank and acknowledge. I'll try not to make this sound like an Oscar speech. So I'll start by thanking our CEO, Dr. Shahid Shafir, our Dean, Dr. Adil Haider, our convener and chair, Professor Zainab Samad, our co-convener, Dr. Usman Fahim, our chair organizing committee, Professor Amir Hamid, our co-chair scientific committee, Dr. Saira Bukhari, that's me, our dedicated team of administrative staff. You were the wheels that kept us rolling: Sana Makhani, Salima Karani, Mariam Kambo, Zara Khan, and Barbara. Our IT team, thank you, Irma and Dr. Mr. Gansham. Communications, thank you, Hania. our fantastic cardiology faculty who work tirelessly to get all of these sessions and these workshops going, and they have been very fruitful. Our nursing colleagues, thank you, Nosheen and her team. Our instructors, fellows, cardiology residents, I like to call them Minoratan, led by Shima Sadia, our chief resident. And our medical students, led by Ali Ahil, Vakas, and Maha, and a huge bunch of team who I cannot thank in the interest of time. And I hope all of you enjoyed Pulse 2021. I hope you will join us next year for some more riveting talks. Inshallah, see you next year. Thank you. Good day and Allah Hafiz.
Thank you so much. Allah Hafiz. Have a nice Sunday to Dr. Zaidi and Dr. Amy, and have a nice Monday to us tomorrow. Thank you so much.
Bye-bye.
Thank you.
Allah Hafiz.
Thank you.
Bye.
Allah Hafiz.
Thank you. Allah Hafiz.